carry that zeal and fervor with us for the academic session, and we have got a stalwart Amitabh Bachchan of endocrine field, Professor Dr. Anil Bhansali sir with us. So he doesn't need any introduction, and he's teacher of teachers. And I'm very happy he obliged us. He agreed to come to Bhopal, and hope will meet his expectations with respect to the academic deliberations. So as you all know, this is an interactive kind of activity where you can intervene at any point of time. So that is the beauty of Masterclass. So Dr. Bhandari will be joining us very soon. So he is actually keeping up with the obesity part. He has gone for a long ride. So after 60 kilometers of bicycle ride, he'll be coming back. So, so this is how the things are. So not taking much of the time, we'll start with the first lecture. And so I hand over the mic to, please go ahead.
A very good morning, everyone. We are fortunate to be guided today by some of the most respected and accomplished medical professionals whose dedication to patient care and medical education continues to inspire us. Let us proceed with our first session. Chairpersons for our first session are Dr. Ashok Gupta and Dr. B.K. Chaturvedi, sir. Dr. Ashok Gupta is a senior physician specializing in rheumatology and autoimmune disorders, and with advanced training and reputed international institutes. Dr. B.K. Chaturvedi is a highly experienced consultant physician with more than 42 years in medical practice, specializing in general medicine, pathology, and microbiology. We are honored to have such eminent leader guiding the session. We welcome you, sir.
Thank you, sir. Thanks a lot. Master classes are known to actually keep all the frills apart. So this is how the beauty of the master class is, and it's been 5 years, long 5 years we are doing this. And the success of master class is because of the people who are attending it and the kind of zeal and fervor and the kind of academic interest they have. So I thought, why not let's start with the lifestyle medicine for obesity management. It's a new thing which has come up, and the foundation of long-lasting health. A new topic, not much new, but something they have aggregated things which are actually more important whenever it comes to all kind of interventions we have for obesity. It starts and ends with diet and exercise. This is also true. So the epidemic of global health crisis, 2.5 billion adults aged 18 years and older were overweight, including over 890 million adults who were living with obesity. So worldwide population affected by obesity in 2022 is quite huge, the humongous figure, 2.5 billion. So, yeah. Endocrinology experts now classify obesity as adiposity-based chronic disease requiring ongoing medical care. This is what the ABCD of obesity is. It's a new definition for most of us because we did not thought that obesity will be considered as a long, chronic illness like diabetes. So that is something which is changing in the last few years. The prevalence of obesity, let's see the Indian context with respect to that, the Metabolic Non-Communicable Disease Health Report. Prevalence of generalized obesity as well as abdominal obesity were reported to be 20% and 20.37% respectively. This is India by SEMA study. Also showed that 54.5% of Indians were physically inactive. With those from urban areas, that is 60% and more inactive than the rural areas. The rural area is surprisingly not behind. Because of, there was a gentleman who visited last week to my clinic. These days I'm going very much against alcohol. So I do write a lot about it. तो बोले डॉक्टर साहब आप बहुत लिख रहे हो अल्कोहल के खिलाफ, पर मैंने कहा ऐसा तो होना ही चाहिए, गवर्नमेंट को सपोर्ट करना नहीं चाहिए इसमें। तो उनका ये कहना था कि अगर अल्कोहल पे आपने बैन लगा दिया तो मेरे जो वर्कर्स मेरे पास काम करने आ रहे हैं, दे विल स्टॉप कमिंग। मैंने कहा हाउ इज इट दैट? बोले खाना तुमको मुफ्त में मिल रहा है, इट इज द अल्कोहल जिसको परचेस करना होता है। तो दिस इज हाउ तो रूरल अर्बन सिनेरियो को क्रॉस सेक्शन अगर आप चाहेंगे तो दिस इज व्हाट इज, एंड दैट इज लीडिंग टू ओबेसिटी। व्हाई ओबेसिटी केयर फेल्स डिस्पाइट पावरफुल ड्रग्स? व्हाई डू मोस्ट पेशेंट्स रिगेन वेट if semaglutide works? Why do we still need lifestyle medicine? So what is lifestyle medicine? The American College of Lifestyle Medicine defines lifestyle medicine as a medical specialty that uses therapeutic lifestyle intervention as a primary modality to treat chronic conditions, including but not limited to cardiovascular diseases, type 2 diabetes and obesity. So this is a kind of new avenue which is coming in. New bottle, old wine in a new bottle. We are integrating people dealing with cardiology, diabetes and other diseases. And they are now, in future, they might come as lifestyle specialists. So it's a rapidly growing evidence-based specialty emphasizing 6 pillars to prevent, treat and potentially reverse chronic diseases, including obesity. The 6 pillars work synergistically to create lasting health transformation. That is nutrition. We have been given, when it comes to nutrition, whenever we invite a dietitian in any of our panel discussions, people, they do ask a lot to that dietitian, and most of my colleagues who used to sit in that panel, यार dietitian के साथ मत बैठाना यार, हमें तो कुछ पूछा ही नहीं जाता. They keep on asking this. So this is very important. We need to get into this nutrition part also. Physical activity, as I'm saying, this is what we do most of the time. We go for a run, we go for a walk, we go for cycling. This is what, as a consultant also, as an obesity specialist also, we should be doing in our routine activities. And yesterday, sir was just telling कि मेरा तो यार TMT करा लिया, just thanks to Indigo. Sir also went for a almost positive about it, but she is very particular. वो अभी डॉक्टर भंडारी आ रहे हैं, ही इज ऑल्सो लाइक दैट. तो दिन भर के अपनी स्लीप का पूरा पैटर्न वो बिल्कुल रिकॉर्ड करके देखते हैं, एंड दे आर वेरी डिस्टर्ब्ड इफ द रेशियो इज लेस. सो सच काइंड ऑफ अवेयरनेस हमारे बीच में नहीं है, वी डोंट हैव इट. बट आई हैव पीपल अराउंड मी हु आर अवेयर अबाउट स्लीप लाइक दिस. स्ट्रेस मैनेजमेंट, अगेन इट इज समथिंग वेरी अनएक्सप्लोर्ड एरिया, एंड टू अ लार्जर एक्सटेंट. टुडे आई वाज जस्ट डूइंग अ फेसबुक लाइव. I was telling कि even the kids are in stress. हमारे समय तो खेलना कूदना मस्ती करना मजे करना यही था. We hardly used to be in stress. एग्ज़ाम के समय थोड़ा सा लगता था क्योंकि साल भर पढ़ाई करते नहीं थे. एग्ज़ाम के समय जरूर लगता था कि यार अब पढ़ना है. But otherwise nowadays the scenario is altogether different. And every now and then you come across a kid who is around 5 years or 10 years and he is weighing in kgs and the BMI is high, percentile body weight is more than 95%, lots of acanthosis, skin tags, and surprisingly there are good number of patients who have type 2 diabetes. So this is alarming difference. So avoiding risky substances, again like alcohol, majorly जिस भी एक्टिविटी में जाओ, शादी में भी जाओ, it starts with alcohol nowadays. अगर वो स्पेशल पार्टी नहीं रखी तो पीपल दे गेट डिसहार्टेंड, यार अपने कॉकटेल नहीं रखा. द काइंड ऑफ एक्सेप्टेंस. एक समय था हमारे यहाँ शादी में अगर अल्कोहल की बोतल खुल जाए तो लोग बड़ा नाम रखते थे. आजकल अगर बोतल ना खुले तो बड़ा नाम रखा जा रहा है. तो दिस इज अगेन अ प्रॉब्लम. दिस इज अगेन अ वेरी बिग प्रॉब्लम. एंड सोशल कनेक्शन, वी आर हार्डली मीटिंग पीपल. सो मास्टर क्लास इज अगेन अ काइंड ऑफ, वी आर ड्रॉपिंग ब्रिज to connect between the specialities. So we do get people from all specialities apart from medicine. So that is how the lifestyle medicine is completed. These are the 6 pillars of lifestyle medicine. And dear friends, they are making us more human, more a doctor, kind of doctor which we used to have. Our forefathers were like these doctors only. They used to be very down to earth people. And nowadays we have been shrouded by information, diagnostics, procedures and all. So we are more of a mechanical doctor rather than a lifestyle doctor. So that completes the definition. And Why it matters despite new medication? Because anti-obesity drugs like SEMA and tirzepatide represents breakthrough but are not standalone cures for obesity. Sustainable result, lifestyle medicine remains the base of therapeutic pyramid, providing the foundation for sustainable long-term weight loss. Behavioral changes are critical. Techniques like motivational interviewing are essential for lasting behavior modification and preventing weight regain after treatment. So combining lifestyle intervention with medications or bariatric surgery optimizes health outcome and maximizes patient success. So there are papers also, the evidence supporting this approach. Even in the era of highly effective anti-obesity drugs, lifestyle medicine remains the foundation of obesity care, essential for optimizing outcomes and sustaining weight loss and reducing relapse. Because even after semaglutide, and Sir is here, he'll be talking in detail regarding GLP analogs and obesity management, there is a chunk. Even in SURMOUNT data, they say 93.6% responded well with respect to some amount of weight loss. What about that additional 7% which were left out? They did not respond to this drug. This might be more with semaglutide, this might be more with other molecules. There are molecules like Orlistat which I use in my clinical practice, but people say यार ये तो बड़ी खराब दवा है, इसका कोई फायदा नहीं. तो अभी परसों ही मैं बात कर रहा था यार, मैंने कहा मैं बहुत छोटा आदमी हूँ, मेरे पास एनेक्डोटल एविडेंस है, बट आई एम फाइंडिंग कि कुछ दवाओं में, कुछ पेशेंट्स में तो Orlistat इज एट पार विद दीज मॉलिक्यूल्स. अगर मैं परसेंटेज निकालना चाहूँगा तो ऑलमोस्ट Orlistat का ग्रुप रख देंगे, वी आर डूइंग दैट स्टडी. Tirzepatide एंड semaglutide, ऑलमोस्ट रिजल्ट्स सब किसी में यहाँ ज़्यादा अच्छा आ रहा है तो किसी में यहाँ अच्छा आ रहा है. तो देयर इज समथिंग विच नीड्स टू इंटीग्रेट ऑल दिस, एंड दैट इज लाइफस्टाइल मॉडिफिकेशन. Because the treatment, the lifestyle medicine will not stop. The nutrition spotlight, the power of plant-based diets, high fiber, low density, nutrient-dense foods promotes fullness with fewer calories, naturally supporting calorie reduction without hunger. Superior weight loss studies demonstrate whole food plant-based diets outperform low-carb approaches. They are coming back to our Indian philosophy of vegetarianism. I'm not against any of the non-vegetarian food, but the whole world is now talking about the plant-based food and diet. A review of plant-based diet for obesity management. It talks about the trial has 75% trial showed significant weight loss. Mean weight change was around 5 kg. Decrease in energy intake with respect to calories, decrease in BP, fasting, HbA1c, total cholesterol, LDL, increase in fiber intake. It led to clinically meaningful weight loss with plant-based diet and improvement in glycemic and lipid parameters. Sustainable options for long-term obesity management. Clinicians should actively discuss diet and support transitions to this plant-based diet. Nutrient distribution, this is medical nutrition therapy. We all know about, we need to keep carbohydrates around 50 to 60% of our diet. The protein should be around 20%, the kind of protein and all. It is all, we all know. We have been discussing this, and fat should be around 20% and should keep the saturated fat less than 7%. And the concept of monosaturated fat has come, gone, and again come back. I'm talking about ghee. There are lots of good things about ghee. Previously, we used to blame ghee like anything, Shuddha Desi ghee. Now, somehow, it's to some extent, we are a little bit moderate with respect to our approach in that. And with respect to micronutrients, definitely these days, and I was just talking about protein intake in elderly. We are not sensitive when it comes to protein intake in elderly. मेरे बच्चे को भी अगर उसे रोज उसके हम एक डब्बे आते हैं, वो खत्म हो जाते हैं महीने भर में. वो फिर बोलता है पापा और डब्बा मंगवाओ. तो माय मदर इन लॉ इज वेरी स्केरी, यार गुर्दे खराब हो जाएंगे, ये हो जाएगा. इवन डॉक्टर्स दे से यार प्रोटीन इंटेक नहीं होना चाहिए, वे प्रोटीन इज नॉट गुड. बट वी नीड टू इंटरवेन, वी नीड टू चेंज आवर व्यूज एंड थॉट्स. That 0.8 grams per kg body weight is for high biological value protein, which we are hardly consuming. We are literally not consuming high. To non-vegetarians हैं जिनका 6-course meal है, 5-course meal है of non-vegetarian food, they are the ones who are actually consuming that 0.8 grams per kg body weight. That stands for them. It doesn't stand for us. Our value is even more. And then 60 plus, I was just reviewing the data. They say even up to 1.2 to 2, when मुझे लगा यार गुर्दे ना खराब हो जाए, मुझे भी डर लगा. Then I went for analysis of data. Those who don't have CKD, those who have other problems, ideally their constituent of protein intake should be like this, 1.2 to 2 grams per kg body weight. The plant-based protein, that ratio is not 1.8. The figure is 1.6. So this is how the scenario is changing, and definitely sarcopenia is something which we don't think of. So the physical activity and sleep essential partners in weight management, they are essential partners in weight management. Physical activity builds muscle mass, boosts resting metabolism, and provides critical mental health benefits. Gradual progression to 200 to 300 minutes weekly is recommended for effective health. Usually we say कि 150 minutes per week, ये तो beginners के लिए है. 30-35 minutes का एक बार का exercise हुआ to start with. अब now I've been exercising since last 8 years, तो 1.5-2 घंटा कब होता है पता ही नहीं चलता. So that is how the scenario is. You cannot start very fast. Initially you'll have to be very slow. But exercise helps. It keeps you well motivated. अब see, he is coming after a cycling of around 70 kilometers, and abhi I'm very sure that after taking this, he will be operating some cases in Indore. This is how these people have the kind of potential. तो पूछिएगा मोहित से, अभी आ ही रहा है वो. So this is how my wife has gone for a 100-kilometer ride today. She will be seeing patients in Bethel throughout the day, and हो सकता है शाम को आके ऑपरेट भी करे. तो ये जो मैजिक है, जो मैं आपके घर का ही मैजिक बता रहा हूँ आपको. This is how the scenario has, and we were not like this some 10 years back. 1 किलोमीटर भी चलना मुश्किल हो जाता था. So this is something, and in between my HbA1c rose to 6.5. Now it is not crossing 5. So this is how the scenario is. So the health, you'll need to this, and sleep, poor sleep disrupts appetite, regulating hormones like leptin, ghrelin, increasing cravings, and promoting fat storage. जिस दिन आप अच्छे से नहीं सोते हैं, उस दिन का दिन आप देख लीजिए, और जिस दिन आप अच्छे से सोते हैं, उस दिन का मूड देखिए, बिहेवियर देखिए, मेमोरी देखिए, इमोशनल IQ देखिए, EQ देखिए, everything changes. The quality sleep hygiene practices improve metabolic health and directly supports weight loss efforts through hormonal balance. Physical activity and exercise for weight loss and maintenance in people living with obesity. It's a beautiful paper. Aerobic exercise, modest weight loss, 2 to 3 kgs, decrease in visceral fat deposity. Resistant training, lean mass preservation during weight loss. Combined training increases VO2 max. VO2 max हमने फिजियोलॉजी में बहुत पढ़ा है, but we are hardly applying it. तो जब मैंने गार्मिन का वॉच लिया तो उसमें VO2 max आने लगा, तो बड़ा अच्छा लगता था यार. देखो 50 हो गया, 55 हो गया. फिर ऑल ऑफ अ सडन जब ड्री ट्रेन करते थे, यूजली कभी कभार हो जाता है 15-20 दिन, तो you used to come down to 45. So that is something again we are not very sensitive of. But nowadays, the people who are engaging in these kind of sports, they are very concerned about VO2 max. The benefits extend beyond weight, cardiometabolic risk reduction. Long-term adherence remains the major determinant of success. Stress and social support, the hidden drivers of weight. The chronic stress impact. Chronic stress triggers emotional eating patterns. टीवी देखते हुए खा लिया, मोबाइल देखते हुए खा लिया. हम पेशेंट आएगा, आपको ऑल ऑफ अ सडन बोलेगा, डॉक्टर साहब मैं तो एक रोटी पे ही हूँ, आई एम हार्डली ईटिंग एनीथिंग. तो द काइंड ऑफ बिंजिंग दे हैव ड्यूरिंग recreational eating, stress eating, emotional eating, these are all dangerous with respect to visceral fat. Stress hormones like cortisol directly promote weight gain and make weight loss more difficult. The power of connection. Mindful practices like yoga, meaningful social engagement significantly reduces stress-related weight gain while improving overall well-being. सबको मालूम है, but we are hardly doing it. Group lifestyle programs, including shared medical appointments, dramatically improves adherence rates and clinical outcomes through peer support. Positive social connections provide essential accountability, emotional resilience, and sustained motivation for long-term success. हो सकता है ओबेसिटी क्लिनिक भविष्य में ऐसी भी हो जहां हम 4 लोगों को बैठा के बात करेंगे. सपोर्ट ग्रुप्स तो बनने ही चाहिए. वेस्ट में बहुत कॉमन है, इंडिया में we don't have a concept of support group because we were social people. हमारे यहाँ चाचा मामा ताऊ सब आपस में जुड़े हुए रहते थे. पर अब न्यूक्लियर फैमिलीज आ गई हैं, तो हमें भी अब support groups की ज़रूरत है. We are hardly interacting. This is again a kind of support group, the Masterclass support group, because here we are sharing our thoughts and views. This is how the things are, but we hardly are meeting people. Mechanically, I keep on seeing patient throughout the week, but personal touch के साथ बोलें तो I'm hardly talking anyone with respect to that. हम तो mechanically हमें लगता है जो ज़्यादा बात कर ले तो back of mind में pressure आ जाता है, यार ये समय खराब कर रहा है. तो वो जो एक inhuman behavior है, that is being inculcated indirectly in our behavior. So effect of this evidence from a published data, 3 months intervention of lifestyle medicine team, including a physician trained in lifestyle medicine, a certified wellness coach, a licensed nutrition specialist, a physical therapist, and licensed mental health professional. This will constitute a team. So improved diet quality and physical activity, decrease in weight, blood pressure, lipid levels, HbA1c was normalized. The clinical message was lifestyle medicine is most effective when delivered as a team. Behavior change in trainable, sustainable and measurable way, and metabolic improvements can occur within months. So busy practice में we don't entertain. If I'm a big practitioner, मुझे कहीं ना कहीं मेरा ego आ जाएगा when it comes to a dietitian वाली बात आ जाएगी तो, या कोई trainer आ जाएगा या कुछ आ जाएगा तो I will not entertain. But dear friends, the era is changing. We'll have to bring out something new when it comes to obesity. It is something which is not going anywhere. It is something which needs to be addressed throughout your life. A real life example, 50 kgs in 50 years, at the age of 50 years. Yesterday only she posted this and she has lost quite significantly. आप सभी ने ये social media पे photograph देखा होगा. So the lifestyle medicine, the interpersonal care team, this is the team, it constitutes like this. And so the key challenges of implementation is limited awareness and education. The medical mindset continues to prioritize pharmacological and surgical therapies, starting from the undergraduate level while overlooking the importance of lifestyle modification. Institutional resistance and lack of integration, the traditional healthcare system is often resistant to change. So we are the ones who are more resistant. If the openness should come from our side, because the implementation requires a lot of engagement of lot of specialities. So bariatric, the foundation stone is like lifestyle medication is the foundation, nutrition, plant-based therapies and all, and physical activity, resistant training, sleep optimization, and then it comes to pharmacotherapy. Then bariatric surgery, if and as and when required. Yesterday, मैंने कहा कि हमारा जो obesity का management है वो burger की तरह है. बोले डॉक्टर साहब ऐसे कैसे बोल रहे हो, burger तो नहीं खाना चाहिए obesity में. मैंने कहा burger के जो दोनों loaves है ना bread के, वो है basically diet and exercise, the lifestyle medication. अब बीच की टिक्की बदलती रहेगी. मैंने कहा कभी मंजरो आ जाएगा तो कभी ओज़ेम्पिक आ जाएगा, कभी ऑलिस्टेट आ जाएगा. तो जो टिक्की है वो बदलती रहेगी पर बर्गर के दोनों लोव्स तो वही रहेंगे. दैट इज लाइफस्टाइल मॉडिफिकेशन, लाइफस्टाइल मैनेजमेंट और लाइफस्टाइल मेडिसिन. तो उस तरह का बर्गर हमें खाना ही होगा लाइफ लॉन्ग. द लाइफस्टाइल मेडिसिन इज द फाउंडेशन ऑफ ऑल ओबेसिटी ट्रीटमेंट. रिमूव द बेस, द पिरामिड कोलैप्सेस. इफ द बेस इज नॉट देयर, यू जस्ट कैन नॉट बिल्ड अप एनीथिंग. सो ओबेसिटी इज अ क्रॉनिक relapsing disease, not a short-term weight problem. Lifestyle medicine remains the foundation of obesity care, even in the era of highly effective anti-obesity drugs. Medications and surgery are adjuncts, not replacement for lifestyle change. Nutrition, physical activity, sleep, stress management, and social support act synergistically. So lifestyle intervention improve metabolic health beyond weight loss. Sustainable success depends on behavior change delivered through structured team-based care. So obesity care is like a tree. It's an analogy. Lifestyle medicine forms the roots. Nutrition, movement, sleep, stress support. Pharmacotherapy strengthens the trunk. And bariatric surgery bears the fruit. Definitely they are bearing the fruit. We are the least paid ones. But without deep roots, no tree stands along. So this is what the medicine is. Thank you. Thanks a lot.
मैं सीहोर जैसे छोटी जगह में प्रैक्टिस करता रहा हूँ करीब 28 साल से। तो पेशेंट को अगर बोला जाए कि और उनको सारा समझा दिया जाएगा, आपका BMI है, आपका फैट, विसरल फैट इतना है, ये 2-4 बार वो फॉलोअप में रेगुलर आने के बाद ड्रॉप आउट हो जाते थे। और जो बढ़ती हुई बीमारी में डायबिटीज़, हाइपरटेंशन, कार्डियो मेटाबॉलिक डिसऑर्डर्स में भी उनकी समझ में एथेरोस्क्लेरोसिस समझाने की अगर कोशिश की जाती है, जो हम लोग मेडिकल में पढ़ते रहे कि एथेरोस्क्लेरोसिस और फैट दोनों ही चीज़ों के कॉम्प्लिकेटेड विषय हैं, वो जो हमें भी आज तक समझ में नहीं आया कि ये फैट मॉलिक्यूल जब लाइपोमा निकाला जाता है तो अपने आप ही लाइपोमा बाहर आ जाता है, उसके साथ कोई वेसल्स नहीं आती और वो बॉडी में कैसे सर्वाइव करता है। फैट सेल, लेप्टिन, ग्रेनुलिन, तो आने वाले स्पीकर से आशा करेंगे कि वो हमें इसके बारे में समझाएं कि ये लेप्टिन, ग्रेनुलिन और जो इंसुलिन रेजिस्टेंस के विषय पे कैसे फैट को कंट्रोल किया जाए। सर ने सचिन सर का धन्यवाद।
We have got a master teacher who definitely will be talking about all of the molecules and parameters basic. So
thank you Dr. Sachin for an enlightening talk. बस moral of the story is कितने अच्छी से अच्छी दवाई आ जाए, आप कुछ भी इजाद कर लो, but lifestyle remains the core thing. Without lifestyle management, all medicines, nothing will work. So lifestyle is the key thing.
sir, what is your take on this, sir? This is relatively, we are just combining everything into a new bottle and nothing else.
Yeah. So I think very rightly pointed out, because the concept is now progressively changing. We always believed that the obesity is a lifestyle disorder. But in fact, initially to begin with, it may be just as a lifestyle or an eating disorder. But later on, it becomes a chronic disease. Because the adipocytes in the people with obesity or diabesity, they are basically dysfunctional. So this has to understand. Because initially what happens that when the insulin resistance mounts up, and then you have got an accumulation of a fat, which is more related to your eating habits. Subconscious eating, which goes on initially, which we don't know, and you continues to gain weight. But eventually, the 3 characteristics of adipocytes have been now very well characterized. The one is the adipocyte size is larger in people with obesity and diabetes. So they have got a larger storage capacity. Secondly, the adipocytes are very avid to accumulate the fat. So the triglycerides are broken down into free fatty acids and glycerol. The free fatty acids easily enter into the adipocytes. Again, the glucose also gets in glycerol. So both makes again the fat. So this avidity of the adipocytes to accumulate the fat in initial phase of a disease makes it more worse. Later on, when the insulin resistance is at peak, it leads to more accumulation of the ectopic fat and visceral fat. So you see the series of events. And thirdly, it is very resistant to leave the fat. Even if there is a fat, because there is a GIP resistance. GIP, it takes out the fat from the adipocytes. It is not able to take it out. So the 3 characteristics, the size is larger, it is avidity for the free fatty acid accumulation, and resistant to leave the fat. Like some tenant comes in your house and stays for 10-15 years. It does not leave the house easily. You have to take the help of the other people or even the legal advice. So same thing is happening here. The adipocytes are accumulating the fat at a high pace, but they are not leaving the fat. So that's why now the definition A, B, C, D, and that's why the all definition has come. You may be thinking it may be a farmer drive also, because they also wanted to make it as a disease. But truly, if you see, even without bias, if you know these characters, that's why the name now is dysfunctional adipocytes. They are not the normal adipocytes. The second point, which is also coming into limelight, is the change in set points. You have to change set points in hypothalamus for your satiation and for your hunger or for your feeding set. The center for the satiation, that is set at a very high threshold in people with obesity. So they never feel satiation with that. And secondly, the eating or the feeding center, it is at a lower threshold. So they continues to eat. So these set points, they are altered by your body image into the hypothalamus. Your hypothalamus always perceives the body images like this. And unfortunately, neither the lifestyle, nor these GLP-1 molecules. They do act on these parameters. So they don't act on dysfunctional adipocytes. To some extent, GIP has got an effect, which I will talk to you. Otherwise, GLP-1, in fact, the GLP-1 receptors are also not present on adipocytes. And so these set points, they do not change. And lastly, when the characteristics of the cell changes, the release of adipokines, your pro-inflammatory cytokines, as well as your adiponectin, they also goes down. That's why this become a liability for the body to have. So lifestyle modification will always be there. Even if you take semaglutide and you don't go for a lifestyle modification, you are not going to lose the weight. It is not a magic bullet or a magic pill that you take the medicine and you will lose weight. It is not, because we have seen now, at least I'll show you some data also, 150 patients we have been with this, all do not lose weight. 5% of the people, even the tertiary group shows they don't lose weight. They are called now by definition as a non-responder in terms of weight loss. So all do not lose weight. That's one very important thing. Even all do not have a good glycemic control, which showing they say regardless of that the good glycemic control is not. People on insulin, people on pioglitazone, they do not lose weight, even with a semaglutide. So there are many limitations, and exercise has also its own limitations. No system can work completely on your biology. So you say that even you do a lot of exercise, you see that if you lose 10% of your body weight, you lose only 1% of hemoglobin A1C. So 10% is a huge weight loss for a given individual, and then gaining a hemoglobin A1C of less than 1%, then you see that you have to do a lot of hectic exercise. It is not a simple walk which may be useful. You have to do a variety of exercises, and particularly more focus on resistance exercises as sarcopenia grows with age, and sarcopenia further grows with SGLT2 inhibitors and GLP-1. So I think the 2 points which should be taken care, the target of the disease is basically adipocytes and hypothalamus. They are targeted to some extent, not to the full extent. And even the drugs in future which will increase the fatty acid oxidation, which will correct the adipocytes, possibly they may change the scenario. But the lifestyle modification remains an integral part. So do at least walk. And some people even say that you do a walk and all. Like one of the patients told that I have already done a 15-kilometer walk in 2 days and rest 5 days rest. Remember that walk every day or 5 days is important, because the beneficial effects of exercise on insulin sensitivity last only for 24 hours. Suppose I say I walked 15 kilometers in one go, my exercise is over for a week, it is not going to benefit you. So the beneficial effect of exercise, even on insulin sensitivity, lasts for 24 hours. So at least do 5 days a week, so you can reap the benefit of exercise on insulin sensitivity. And many things more on diet, because the proteins are very, very important. And why they are important? Because our diet is mainly carb-rich, whether it is the North or whether it is the South India. So with the protein, you have got 3 major advantages. The one is protein gives a lot of satiation, which is not with the carb and not with the fat. So secondly, the protein has got the highest amount of DIT, diet-induced thermogenesis. For the digestion, absorption and assimilation of the proteins, you require a high calorie content, high energy. As opposed to carb and fat, they are easily digested, absorbed. So I don't say waste, you invest a lot of energy into the digestion of proteins, which you don't invest in carb and this. So if you don't invest it, so it gets accumulated. And lastly, the proteins has got a minimal effect on beta cell. Like with a carbohydrate, you have got a very exuberant response to insulin. While with the proteins, you have got a minimal response to insulin. So hyperinsulinemia, which you have following a meal, is much lesser with the protein-rich diet as opposed to carb-rich. And more hyperinsulinemic response you have, more you gain weight. Because the previous concept was have a 5 times a meal or 6 times a meal in a people with diabetes. More frequently you take a meal, more frequently you develop hyperinsulinemic peaks and you develop obesity. So now even for a people with diabetes, the recommendation is they should have 3 meals in a limited period of time. And the rest of the period, should remain that there should be no insulin peak at all. If you have a more insulin peaks throughout the day by munching or by interprandial eating, you are going to lose the benefit of the weight loss. So I think many things have come new, which I will share with you.
Thank you, sir. Thanks a lot.
Let's proceed for the next presentation.
Yeah.
Thank you so much, sir, for this insightful session. Now, I would like to invite Dr. Anil Bansali, sir, to felicitate our chairpersons, Dr. Ashok Gupta, sir, and Dr. B.K. Chaturvedi, sir. Thank you so much, sir. Now, let us proceed to our next session. I invite Dr. Priksha Trivedi ma'am, Dr. Sanjay Gupta sir, and Rajesh Bhanchani sir on stage. Dr. Priksha Trivedi is the first GMT rheumatologist of Bhopal and Central India. She is an associate professor at GMC Bhopal and holds her DM from PGI-MER Chandigarh. Our next chairperson is Dr. Sanjay Gupta sir. Dr. Gupta holds advanced qualification including MD, DM and DNB in nephrology, reflecting his strong academic background and specialized training in kidney disease. Dr. Rajesh Bhanchani is a well-known senior physician and critical care specialist with close to 30 years of experience. He is an MD from GMC Bhopal and an active member of Indian Society of Critical Care Medicine. We welcome you, sir.
So, good morning, everyone. Let me introduce the speaker, Dr. Anil Bansali, sir. He is a Director, Kidney Health, Mohali, Professor and erstwhile Head Department of Endocrinology, PGI-MER, Chandigarh. More than 500 publications with the H-index 76 and more than 50,000 citations. He is a Dr. B.C. Roy Awardee, former President of ESI in Punjab RSSDI, author of Clinical Rounds in Endocrinology, pioneer in community research in diabetes and stem cell therapy in India. And we have just heard his eloquent comment on obesity. So, without wasting any time, I invite Dr. Bansali to go on the subject.
Thank you, chairpersons, for kind introduction. At the outset, I am thankful to Sachin for inviting me for this obesity masterclass. And I am doing these programs for these companies for last so many years, at least for last 2 years now, for this both tirzepatide and then this. So we have become partly wiser to some extent, and partly we have learned that these molecules are definitely going to change the whole scenario. So obesity is growing, such very clearly showed. That was also part of our data because I was the part of the ICMR and diabetes study for Punjab and Chandigarh. So this paper published in Lancet Diabetes and Endocrinology. So you see that how many people with obesity, diabetes, and it's a growing problem throughout the globe. It is not only in India, but it is going partly because our population is more, but still China also exceeds more than us. So, but the lifestyle and the possibly the maternal malnutrition and these factors possibly may be contributing for more obesity, and adolescent obesity is also on rise because the change in the lifestyle and eating pattern of the growing adolescents. Whether these molecules really can help in the curtailing the incidence of obesity, or they will be really helpful in the people with diabetes. So I think these are the recommendations in 2026 by the ADA, and that shows that the GLP-1, you see that previously we used to talk about the metformin, lifestyle modification and all, and now here the GLP-1 now comes to the people, those who have ASCVD. So even as an initiating agent in people with ASCVD, it has come this. This is not because of the improvement in a glycemic control. This is mainly because of the non-glycemic benefits of these medications. That is very important to have or to harbor in the patients with established ASCVD. Similarly, SGLT2 for people with those who have heart failure, or those even for the primary prevention of heart failure, SGLT2 works, and people with a diabetic kidney disease, they do work. So the showing this slide only means that in a very short span of time, these molecules have got a place in the management of type 2 diabetes as at level 1 or at tier 1. And even the people with a multiple cardiovascular risk factors, even without established ASCVD, these molecules do work as a part of the non-glycemic benefit. So I'll just tell you, I will remind you what is the incretin. I think when I track the history, the first person who reported the effect of incretin or as an incretin-like substance, that was way back in 1903. And the person was Murray. So he published this paper in 1903 in Journal of Biological Chemistry. And what his observation was that when he gave the duodenal extract, I don't know why they were giving a duodenal extract, but he gave a duodenal extract to the people with diabetes. And even at that time, the method of estimating the glucose was not available. So he mentioned in his paper, reduction of glucosuria. So they were possibly doing the Benedict's test, and they estimated that. So those people with diabetes, they were having the duodenal extract, they had a reduction in glucosuria with the use of this extract. So that was the first observation which made the Murray in 1903 and published this observation way back at that time. So what is the incretin effect? So incretin effect, and then it became possible to measure the insulin in 1969 when the Burson and Yellow, they invented the radioimmunoassay. And the first hormone which came into that, you have the insulin resistance. That was the first observation because the insulin was the first hormone which was measured by the Burson and Yellow, and they found that the glucose and insulin levels are both high. So then they coined it, the first described as insulin resistant in people with diabetes. So what is the incretin effect? Incretin effect means the difference between the insulin secretory responses to, so you give an IV glucose and you give an oral glucose. So if you give an oral glucose versus IV glucose, the insulin response is much, much higher with the after the oral glucose ingestion as opposed to IV glucose. This happens despite the glucose levels are much higher with the IV glucose as opposed to oral glucose. However, later on the isoglycemic profiles were done. So you achieve the similar levels of glucose after oral as versus IV by possibly ingesting the similar amount of the glucose required for the same response. So still they found that even having isoglycemic profile, the insulin response was much more exaggerated after the oral glucose as opposed to IV glucose. It means that something is in the gut which is responsible for the exaggerated insulin response in response to oral glucose load. However, with the IV glucose, you didn't find the similar response. But in people with type 2 diabetes, the insulin response is lost. And possibly, one of the reasons for this is they are having a GLP-1 deficiency with that. So with the diabetes or with the onset of diabetes or with the progression of a diabetes, the incretin response is reduced, particularly GLP-1 goes down. And the reason for that, why the GLP-1 goes down, mainly possibly because even the people with diabetes, they have a subclinical gastroparesis. So this subclinical gastroparesis leads to delay in exposure of the nutrients to the L cells and K cells of the small intestine. The another explanation, possibly it may be L cell glucotoxicity, which might be responsible for the decrease in insulin response from these endocrine cells. And lastly, people who are destined to become diabetic genetically, so they might be having a deficient GLP-1 response. Opposed to that, you have a GIP, which is a GIP resistant state. So here the GIP does not work, and GIP preferably have got a more response even after meal, because the 2/3 is contributed by the GIP. But in addition, the GIP also has got an influence on adipocytes, because the GIP receptors have been shown to be present on adipocytes, and you have got a GIP resistant state. A GIP causes lipolysis in a fasting state, so that process is defeated. So what we want to show that the people with type 2 diabetes, their incretin response is slowed down, they are relatively GLP-1 deficient, and they are GIP resistant. So what are the ingredients? They are entropeptides released in response to nutrients, GLP-1 in response to carbs or glucose, while the GIP in response to glucose and free fatty acids from the L and K cells of the small intestine respectively. Both ingredients stimulate insulin secretion in a glucose-dependent manner. So that is one of the beauty of this as opposed to sulfonylureas. Sulfonylureas continues to stimulate glucose regardless of the glucose values. While the incretins, because the insulin is always stimulated in a glucose-dependent manner, whether it is the endogenous glucose or whether it is the GLP-1 GIP. So as the glucose levels goes below 70, the GLP-1 mediated insulin secretion is decreased or lost. Similarly, the GIP also, the glucose mediated insulin secretion is decreased by the cutoff at 70. So below 70, because you require the presence of glucose, and the glucose entry into the beta cell is reduced when the glucose levels are below 70. So that's why you don't have a hypoglycemia with these class of drugs. You can continue to achieve even the glycemic targets, even 7, 6, or even up to 5. So it's a glucose-dependent insulin secretion, means as the glucose level goes down below 70, there is no glucose entry into the beta cell, no cyclic AMP, no insulin secretion, because these two molecules, they act through GPCR, that is G protein coupled receptors. The GIP, the GLP-1, I think another important point on alpha cell. The GLP-1 inhibits glucagon, while GIP inhibits glucagon, so that protects you from hypoglycemia. That's why we have used the word GLP-1 inhibits glucagon regardless of glucose, while the GIP inhibits glucagon in a glucose dependent. When the glucose levels are low, the GIP stimulates glucagon, and incretin response is impaired in patients with type 2 diabetes. This is just a summary for the convenience of the residents and students, how the GLP and GIP, they do differ. Both are peptides. One is from L cell, other is from K cell. Stimulus is glucose and free fatty acids. On a beta cell, there is a glucose-dependent insulin secretion through GPCR, stimulates glucose-dependent insulin secretion through GPCR. Incretin effect contribution 1/3 and 2/3. So means the GIP contributes to a larger extent of insulin secretion for postprandial glycemia. On alpha cell, inhibits glucagon in glucose-dependent manner. Hypothalamus, that's very important because you require at least 4 to 5 times higher concentration of a GLP and GIP to have an effect on the hypothalamus. It suppresses appetite, it increases satiety, and induces nausea. That's one of the mechanisms for the side effects associated with the GLP-1 analogs. So it is mainly the mechanism. It causes gastroparesis also, but it's a central mechanism. So the ondansetron is a better choice to ameliorate the side effects of a GLP-1 analogs as opposed to this. It suppresses appetite. There is no effect on satiety by the GIP and decreases nausea. The craving for carbs and fatty foods is reduced with GLP-1, but it's remarkably reduced with GIP. And on adipose tissue, it increases glucose and free fatty acid uptake in a postprandial state, while in a fasting state, it causes lipolysis. So GIP is a double-edged. In a postprandial state, it causes lipogenesis. It promotes the activity of insulin through insulin, and while in a fasting state, because after the using of GLP-1 analogs, patients remains more or less in a fasting state, so there is a more lipolysis. So losing and maintaining weight loss with diet and exercise alone is a constant struggle. You lose weight by making you calorie deficient. You lose weight by enhancing the physical activity, but eventually after some time you gain weight. And the reason for gaining weight is that because all the mechanisms which causes obesity, they again become reoperative after some time. Because exercise itself has got its own limitations to reduce the weight. By maximum exercise, like in a diet and lifestyle, in a direct trial, there was a loss of 15 kg weight. But the 15 kg weight loss of 15 kg could not be sustained for a long time. Of course, they had a remission of diabetes in 75% of the people in the first year. So the weight loss and weight gain always is a struggle. You lose weight, but after some time, there is a gain. That's why we say obesity is a disease rather than it is only a lifestyle problem. So, adipocyte dysfunctions and obesity, the size is increased, as I mentioned. There is enhanced lipolysis due to insulin resistance at adipocytes. So more free fatty acids and more fat accumulation into the liver, pancreas, and heart. So now the kidney is also target. Now the people call it a fatty kidney disease. Similarly, the muscles also accumulates a lot of fat. It is called as a fatty muscle disease. So you will see the fat everywhere. And even in the people with diabetes, they have shown the muscles of the people with diabetes, they are white. It is called as a marbleization of muscle. While in a normal people, we expect the muscle fiber should be red. So it is not red, but it is because of white, it is because of accumulation of fat. And why there is a more accumulation of a fat? Because the fat, rather than going to be deposited into adipocytes, it's diverted to these eutopic sites. And eventually, when you have a more fat in different target tissues, you have a chronic inflammation, and this leads to more complications and problems. So incretin analogs, now they are classified into currently three, it may be number more: single agonist, the dual agonist, and a triple agonist. The single agonist includes GLP-1, that is semaglutide. The dual agonist, GLP and GIP, tirzepatide. Triple agonist, GLP-1, GIP, and a glucagon agonist. So even the glucagon also has got an effect on hypothalamic centers, and it can also reduce the weight. What happens with increasing agonistic activity? The weight reducing potential progressively improves. You lose around 10 to 12 kg with SEMA, 12 to 15 kg with Terji, and even 20 kg with triple agonist. The hemoglobin A1C reduction efficacy also improves with the increasing the agonistic activity. However, adverse effect profile worsens with increasing agonistic activity. So the semaglutide, a dose of 2.4 milligram, it works in the key areas of the brain and it reduces the appetite. It has got almost 94% homology to human GLP-1. The T-half is approximately 1 week. That's why you give it once a week. It's directly activating the hypothalamus and leading to increase in satiation. In addition, it also has got an effect on appetite. It suppresses appetite by acting on nucleus of Tractus solitarius. In addition, the semaglutide has got a not only effect on the homeostatic regulation, means your daily eating, but it also on a hedonic eating. Hedonic means when you don't feel hungry, but still you eat. So it's eating for the pleasure. So you eat many times. Your stomach gives a sensation that you are full, you don't need, but the brain says that you eat, and you eat. So it's a more hedonic regulation. So hedonic eating is also highly prevalent in people with obesity and diabetes. So many times you have got a disconnection between the signals from the stomach versus signals from the brain. They over-dominate and you eat even you are not hungry. So you have data from so many trials they have already made, but we'll have some discussion on this. So step 1 was basically a 2.4 milligram in patients with obesity, and they showed that weight loss was something around 16%. So average weight in this study was 104 kg. So roughly you'll lose 17 kg weight with the use of semaglutide over a period of 50 weeks. However, there is a flat or almost still continues, though it is a lower pace. When we ask that why the weight loss is faster in the initial days or initial weeks as opposed to later, the reason for that, you initially lose water as well. So once you lose water, you lose fat, you lose to some extent lean muscle mass. So the initial weight loss is much faster and higher as opposed to the weight loss which occurs in the later phase. However, the weight loss continues over a period of time till you continue the medication. We'll discuss whether these therapies should be given lifelong or should be given for a time being. Then, so meaningful weight loss, how much weight loss? 1 in 3 patients, almost 33% of the people, they lost weight more than 20%. However, the 5% of the people, they did not lose weight. So they are called as non-responders. So the definition of non-responder is if the weight loss is less than 5%, then we say non-responder. And the 5% of the people, they do not lose weight. That may be one of the example of the biological heterogeneity, where all people may not lose weight with these molecules. In addition, the other health parameter, they do have a beneficial effects on blood pressure, on waist circumference. Almost for a 1 kg, you lose 1 centimeter. Improvement in CRP, improvement in HbA1c. So everything happens with that, and all metabolic parameters, they do improve with this semaglutide. Then the more than 1/3 of the people, yes, what happens if you discontinue? Then usually there's a weight gain, roughly almost 1/3. Start gaining from the day when you discontinue, and almost by the period of say 70 months, so roughly around 50 months is required to regain the weight over a period of time. So almost you can say that the 1/3 of the weight is gained within next 50 months and continues to gain later. We don't have a data for this, but likely to, because the graph is rising in that way. So you regain weight once you discontinue these molecules. Initially maybe much less, but later on the weight gain is almost in 1/3 of the people. Then you have a MACE. That is a very important point because you have one of the 20% reduction in the major adverse cardiovascular events. So that's another advantage with this, and that is also as a part of the primary prevention. So you can use these molecules. This is one of the known glycemic benefits. That's why I told you ADA and ESD says that you use in a people with ASCVD or people with multiple cardiovascular risk factors. Then you have the risk reduction. Another important point is the risk reduction in a cardiovascular events happens early. Initially we thought even as early as 12 weeks. So why it is happening so early? So it is possibly a beneficial effects on hemodynamics to some extent. It is not the atherosclerosis, hemodynamics or endothelial dysfunction or on a cardiac myocytes. So they might be having a more beneficial effect on those which may be responsible for improvement in a MACE or major adverse cardiovascular outcome even at 12 weeks. In addition, the CV death is reduced by 15%. That's another advantage with that as a secondary endpoint. And finally, the MASH. The fatty liver is highly prevalent, and now they have shown that there is not only decrease in steatosis, but there is an improvement in fibrosis also. So far, we had only one drug, which was a pioglitazone and dapagliflozin and empagliflozin. They do have an effect on steatosis, pioglitazone, as well as on steatosis plus on fibrosis, but this molecule also has got a beneficial effect on this. So the organs which are basically targeted by the ectopic fat, they do have a really benefit in the outcome on this. So your kidney, your liver, and your heart all have got a beneficial effect, and in addition to losing weight. So the another molecule, the tirzepatide, that is a dual agonist. We have a lot of data on this issue also. So weight reduction is slightly higher. So it was a 16% with SEMA, here is a 22%. So dual agonistic, they do have a more weight loss as opposed to this. This is because of the additional effect of GIP. Almost you gain around 11 kg weight over a period of roughly around 40 weeks after discontinuation. So weight gain is, or regain is a natural phenomenon once you discontinue these molecules. So side effect trial, the both have been almost equal. We possibly thought that the tirzepatide may have a lesser side effects because it suppresses nausea. GIP has got an effect on nausea, but in clinical data which shows that the side effect profile is same. So when to use? So in clinical practice, the purpose for a weight loss, the BMI, if it is more than 27 with obesity associated comorbidities, which may be metabolic, which may be mechanical, or which may be mental. BMI more than 30, regardless of comorbidities. So it is all people related to obesity who do not have diabetes. In addition, the people who have got a concurrent presence of ASCVD, multiple cardiovascular risk factors, heart failure with preserved or reduced ejection fraction. So even their BMI may be 25, but still you use these molecules for the known glycemic benefits. In patients with DKD and albuminuria, these can be added as a fourth pillar. You already got a 4 pillar for a DKD, that is your ARBs, SGLT2 inhibitors, finerenone, and semaglutide. You can use all in patients with MASH, and additional reduction in hemoglobin A1C once you fail with 3 OHAs or basal insulin. So I think there are some indications for a clinical use. It is not necessarily always for weight loss. It is necessary to use either a good glycemic control, fatty liver, or DKD or ASCVD, where weight may not be the target. What should be the checklist prior to use? The pancreatitis history of acute or chronic pancreatitis should be excluded. And the reason for that, however, the incidence of pancreatitis with these molecules is very uncommon. It's very rare in that way. But those who had a past history of recurrent pancreatitis should be not included in the study. People with a medullary thyroid carcinoma should be out. People who have got a symptomatic gallstone disease should not be given because it can exacerbate. But those who are having an asymptomatic gallstone disease can be continued or can be used. And prior ultrasound abdomen is not required to initiate the therapy. Recently, some data have come, people with other thyroid carcinoma like follicular or papillary, because the GLP-1 receptors not only present on the C cell, but they are also present on the thyroid follicular cell. So people who have a history of, personal history of thyroid carcinoma, I think should have a thoughtful consideration. The adverse event profile. The gastrointestinal happens in 20 to 30, it is wrong. It's a 70 to 80% of the people. It's a nausea, vomiting, diarrhea, and constipation. You can have a severe abdominal pain. Some patients may experience acute pancreatitis. There may be a worsening of the gallstone disease, and some people may have a local site reactions. The 2 other side effects which we recently noted was loss of scalp hair, one, and secondly, there is an intermenstrual bleed with these molecules. Explanation for that was not available, but the 2 observations or 2 side effect profile was noted like that. Worsening of diabetic retinopathy have also been observed. This can happen with any molecule which reduces the blood glucose faster. The NAYAN, that is a known arthritic ischemic optic neuropathy. Now the current analysis shows there is no increase in incidence as compared to placebo. No cause and effect relationship is established. You can also have acute kidney injury with these molecules, possibly because of severe vomiting, diarrhea, or decreased fluid intake, and it's more prevalent in patients with DKD. The euglycemic decay have also been reported with semaglutide. It's a poor oral intake and GI-related adverse events. And lastly, some data from Australia have also reported depression and suicidal thoughts. However, again, it is not the case control study, it just is an observational study. How do you overcome the adverse effects? The monitoring for amylase, lipase, calcitonin during follow-up is not required unless someone really has got a very severe abdominal pain or intractable abdominal pain or nausea and vomiting, otherwise you don't require. There is no dose modification in the liver and kidney disease. You can use the maximum tolerated dose as possible. Pregnancy and lactation not to be used, and contraception advised to all women in a reproductive age because it can induce ovulation or it can improve ovulation, so the fertility can happen. How to manage adverse effects? On administration and timing, injection can be given in the evening, so patient takes and then can sleep. And build up the doses gradually. Never to be in a hurry. You start with a recommended dose of 0.25 or a 2.5 as recommended and build up slowly. The slowly built up leads to better tolerance, better improvement in there is an insensitivity to gastroparesis, and you can give the small meals on the day of injection and day 2, plenty of fluids. Alcohol should be avoided on day 1 and day 2 and 3. Carbonated drinks should also be avoided because they can induce more nausea and vomiting. The ondansetron is a better choice because it has got a centrally acting drug and H1 receptor blocker as opposed to the PPIs. Amla candies can also be used and loperamide for diarrhea. For escalation, if severe and prolonged GI adverse events, you exclude pancreatitis, GSD, gallstone disease, and rarely DK. So monitoring is very important because we have 2-3 patients, they had a severe abdominal pain, required admission, but fortunately, the amylase and lipase were only less than 2-fold elevated. So it was not a pancreatitis, it was just as an abdominal pain. How to manage adverse local site reactions? You change the site. Antihistaminics can be added for that. Alternative therapies change to incretin analogs. So question is when to switch. So like you switch from rosuvastatin to atorvastatin or vice versa. Sometimes you switch from AMPA to DAPA or DAPA to AMPA. So what we have seen in our clinical practice, it is not part of literature, but so sometimes it is better. Secondly, failure to attain the glycemic targets with maximum tolerated doses. Again, you can switch to that. The weight loss is similar. We didn't find the weight loss much in people, those who are on insulin and those who are on pioglitazone for some or other reason. So I think there are some observations which we have made. And acute kidney injury we have seen more commonly, particularly those who have a severe diarrhea or a severe vomiting. So if you miss the doses of these molecules on the next day, so if you miss for a consecutive 3 days, then you have to change the day. And if you miss up to 3 days, then within 3 days, you can use the dose in the same way. Then question is how long to continue. This is a very worth question, and because every patient asks, it's a very expensive drug. One, side effect profile is not usually pleasant. Because even we say that the adverse event profile, it goes away with time. Patient develops tolerance, but patient says that up to 3 days after the injection, they are restless, they are more fatigued, they are not able to eat anything. So they are not comfortable for the next 3 days, even after, say, 3 months of the therapy. So the many patients are asked to stop or to discontinue. So discontinuation is much higher in our population as opposed to the data which we have seen in Western population. So how long to continue? As I mentioned that both the studies from both tirzepatide as well as from semaglutide, they have shown very clearly that if you discontinue, the weight starts again rising. So people have made many avenues to maintain the waist loss. That is a lost weight. That is a very important. How can you maintain the lost weight? So people have come to microdosing. They have put on again in a low dose, like 2.5 milligram or a 5 milligram of tirzepatide they have continued, while some people with a semaglutide only 0.5 milligram as a maintenance dose. Some people have even the frequency. So rather than giving it a 7 days, it has given 10 days. So microneedling is official, but some people unofficially they have done like that, and their symptoms are relieved for a longer time. So why we need this as a lifelong? Because the discontinuation data very clearly shows that there is a regain of weight, though slow, but you usually gain almost whatever you weight lost, 40 to 50% within the next almost 1 year. So why this is happening? Because the drug does not target the set points. It has got an effect on set points, but it does not alter the set points. Then the question which is usually asked, how much time you take to alter, change in the, or altering the set points? So possibly if you maintain the weight for say almost 3 to 5 years, lost weight, then your set point possibly may change. But we don't have an answer of this question. So the set point theory, which is important for satiation and appetite, it can change, or these set points in hypothalamus may change if the weight loss or lost weight is maintained for a prolonged time. Secondly, if you have an improvement in the functionality of the adipocytes, then possibly you may have a more beneficial effect and sustained weight loss. So you can see that the chronic relapsing and remitting disease, because adipocytes are dysfunctional, hypothalamic set points are altered, these are corrected, at least not in 2 years or 3 years. These may be corrected if you maintain the lost weight over a period of 3 to 5 years. So 4 weeks, the weight loss does half of the lost weight is gained in next 40 weeks. So weight regain is not a insurance or not a insurance with these molecules, but you continue to have a lifestyle modification. And I will tell you, there is no negotiation with lifestyle modification, even you use these molecules. Lastly, I didn't talk about the sarcopenia. I'll just tell because this was not mentioned in the slide. So sarcopenia is one of this, and recently the data of the semaglutide have come. They did a body composition analysis, and they showed that the 85% lost weight is because of fat, and 15% lost weight is because of the muscle. Even in the muscle, the argument is that because muscle have also got a lot of fat in people with obesity as well as in people with diabetes. So it may not be truly the lean mass loss, it will be with the loss of fat from the muscle. Because the muscle has got a lot of fat, not into the interfiber, but intrafiber also, which can be easily seen by the MR spectroscopy. So they say that the loss is, yes, overall it goes from a muscle, but even in the muscle, the lost muscle is basically the fat in the muscle. Secondly, in people with diabetes as well as with the growing age, you lose almost 1% of your muscle mass after the age of 30 years with growing age. That's a natural phenomenon. So that may be possibly related to aging. That may be possibly related to decrease in vascularity. That may be possibly related to ongoing hypogonadism with aging, and that may be possibly related to somatopause. So there are many reasons to lose the muscles even in the normal people when they age. But in people with diabetes, the age of muscle loss is much faster. They lose rather than 1%, they lose more than 2%, even 2.5%. Another problem in people with diabetes is that even you eat proteins, even you take a good quality, high biological value proteins, whey proteins, the incorporation of the amino acid into the muscle fiber is also impaired in people with diabetes. That can be only improved by good glycemic control, one, and secondly, by resistance exercises. Brisk walk may not be the good answer to maintain the muscle mass. And recently data have come, they have shown there is an improvement in the hand grip strength with the use of semaglutide in this. So the muscle mass loss is there, I don't deny, but it may not be significant because there is improvement in a frailty with these molecules. So your hand grip strength improves, your chair raising test and getting up from the chair, it also improves with these molecules. So meaning by that, if you take a good amount of protein, do a resistance exercises, you can maintain your muscle mass. So the risk of losing the muscle mass is also minimized. So to conclude, obesity is a chronic, progressive, relapsing and remitting till we target the pathophysiological mechanisms both at set points and at dysfunctional adipocytes. And it requires long-term management both from the medical control. and even the fatty liver outcome. And adverse event profile, I think if you go slow, you target the adverse effects appropriately, they should not preclude their use and should be managed on individualized basis. I think with these remarks, so I finish my talk. If any questions or comments, we'll be happy to answer.
Thank you very much, sir. A very phenomenal comparison between the two giant weight reducing molecules. Now, can you just give me a clue that how a physician or an endocrinologist can decide with the profile of the patient that he should go for Wegovy, oral or injectable or to conjure?
Okay. So first question is related to oral versus injectable. I think that's the one point which you want to ask. And then we'll ask SEMA versus injectable. So we'll answer both the questions. So first is that when we had a Rybelsus or a oral semaglutide, we didn't have any option of using injectable semaglutides. And the people always have a preference for using an oral tablet. But you remember that with the oral semaglutide, even you reach up to a dose of 14 milligram, the average weight loss is around 5 kg or 5 to 7, I think must. Because every day you have to take a tablet, you have to take a precaution for 1 hour, not to take anything. And if they are on thyroxine, again wait for 1 hour to take thyroxine and take with only half glass or even with a sip of water. So the administration is also cumbersome. When we talk about the injectable, because injectables are easily accepted by now the patients, is because it's weekly. So because of being a weekly preparation, the patients usually accept easily. The another reason for using weekly is now the cost-wise they are cheaper as opposed to the oral. And thirdly, the potency is definitely more. You lose around 15 kg weight with the oral semaglutide with a dose of 2.4 milligram or MTD maybe around 1.6 milligram as opposed to the dose which you use in that. So they are more potent, they are more effective even in reducing hemoglobin A1C once a week. Side effect profile may last for 1 or 2 days or 3 days, not for the whole week as you have with a oral semaglutide. So I think the preference is changing. Still, I think hardly even less than 5% of the people now they insist on oral. So I think overall we feel the trend for oral is going down. And it's a more a preference for the injectable. Choosing SEMA versus tirzepatide. If you go for the data are more in favor of a tirzepatide because even the MTD of 15 milligram or 12.5 to 15 milligram, this bracket, they have got a weight loss something around 22 kg. So got a very higher weight loss because you can argue the baseline weight was also 104 kg. Our people may not have a baseline weight of 104. They are usually 90 kg or 85 kg. So higher the baseline weight, higher is the reduction. But in clinical practice now what we are seeing, the weight loss is almost comparable with both the molecules. So I think you can start with any molecule, whatever you like, but you may require a shift. If you do not achieve the target, adverse event profile is worrisome or not tolerable, or lastly, if you are not able to achieve the hemoglobin A1C. So I think the maybe switch, maybe one of the things, because switch I have talked. The data from the available from literature, they don't talk about switch. But switch is very likely to happen because you got to switch for rosuvastatin, you got to switch for a atorvastatin, you got to switch for a DAPA and AMPA. The switch is likely to happen. So I think you can start with a SEMA, single agonist, see tolerable or not. Then you can switch to tirzepatide if the weight loss is not there. And the cost-wise, the SEMA is now much cheaper than the tirzepatide.
Need to screen the patients for neuropsychiatric disorders before starting these drugs?
It does not. Yes, so far guideline does not recommend because this was just as a report from the observational data. There are more depression and suicidal thoughts. So I think if you were to really find a history of a parasuicides, then possibly you may consider, otherwise a prior workup is not as a part of the guideline. And now they also refute because the data which is emerging, but again it is not a RCT, they are only observational studies, but they show that there are no much increase because these people already had a background disease, so it was not the related to the drug.
Sir, my discussion goes to actually obesity is a complex thing. It's heterogeneous. The pathophysiological mechanisms are also heterogeneous. And then one therapy doesn't fit all. Then you need to intervene through several mechanisms. Nowadays, there are certain discoveries are going on and research is going on where they are going for GIP antagonists also, which are...
Like you are using a GnRH agonistic analog. Initially, they will cause agonism. Later on, it will be an antagonism because of the receptor downregulation or receptor desensitization. So any agonistic hormones later on will eventually become an antagonism by its virtue of the receptor or post-receptor property, signaling mechanism properties. So the explanation for that, why some people are using GIP antagonist and as opposed to the GIP agonist, it has also shown, so agonism eventually later on become antagonism. That's one explanation for that. However, both the companies from the available literature, they are silent on this issue that why they are using agonistic activity or not. The second question which you asked, physiologically, the GIP promotes lipogenesis. It's a GIP promotes insulin-mediated lipogenesis. But whenever so it is an insulin-dependent lipogenesis, means insulin levels are higher, it will promote lipogenesis. When the insulin levels are lower, it will promote lipolysis. When you use these class of molecule, most of the time your passes in low insulin phase because you are not eating. So if you don't eat, the insulin levels for relatively will be lower, and at that time GIP will act as a lipolytic. So that's why I use the two words. It's a glucose-dependent manner and it's an insulin-dependent manner. So lipolysis is promoted by the GIP in a fasting state, and you remain more or less in a fasting state. To metabolize the fat by the
for the action of the GLP and GIP. So beta cells are not, it's a functional failure in people with type 1 diabetes. And still, they have been shown to be some useful type 1 diabetes, which is easily
also be curtailed to some extent by the use of these molecules. And thirdly, the case and some anecdotal reports. If you see the Google, you will find some case use of a gene for a lipodystrophy. And I have also used in people with a post-op craniopharyngiomas who are getting excess of weight. And in one patient of a Prader-Willi, I have also used in that. So these are some anecdotal reports, but some literature was there, so I thought we should use in those individuals also. But what about the? So particularly for Alzheimer's, they have shown some data in a mice. The animal data range in glycemic variability. Type 2, certainly. People with obesity, certainly. People with ASCVD, DKD, and people with fatty liver, MASH, yes. Swimmer, yeah. Certainly, sir. Physical activity, no physical activity versus some physical activity versus intense physical activity, all good. If you don't do anything, it is. So swimming is a good exercise, so do swimming, but you do a variety of exercise. Even for exercise, now the recommendation is you do a variety of exercise. If you do only brisk walk, 10,000 steps a day, now the people are reducing to 8,000 steps a day. So roughly if you walk 10,000 a day throughout any time of the day, then you find that the cardiovascular outcome or cardiovascular benefits are there. And now say people said even you do 8,000 steps, it is good. You can do at any time of the day or the whole day you can do, but total make it 8 to 10,000. But this is basically for a cardiovascular fitness. You require some sort of a resistance exercises for maintaining the muscle mass and muscle function. For that you require the gym-like weight bearing. If you can't go to the gym, then you can do the push-ups and sit-ups. So that is another good exercise which you can do. And swimming is another good, can only be maintained by the yoga. So I think that's one principle which I have also realized. If you do yoga, you feel more fit. If you do even a 10 Surya Namaskars a day, I think you are more fit than even you do a brisk walk. So I think you should prefer more for it's definitely bad. Do something, even you don't achieve a target of 10,000, even 5,000 is good. There is another study which we published 4 or 5 years earlier, the exercise post-meal walk versus the pre-meal morning walk. The post-meal walk is better. 15 minutes walk after 15 minutes of meal, if you do it, it is much better. It could reduce hemoglobin A1C by 0.8%. So it is better if you do the same morning walk in the morning hours as opposed to this. So that's a very important that the post-meal walk can control a better hyperglycemia, post-parental hyperglycemia, because the glucose entry becomes insulin independent in presence of exercise. And the only muscle in the body where you don't require insulin is soleus. Soleus is the only muscle, despite being a skeletal muscle, it does not require this. So that's called as a peripheral heart. So it works maximum when you do a brisk walk. So I think that's why we say that you should do like that. And secondly, another phenomena which is a late night dinner, which is a very common phenomena prevalent in we people also as a professionals. So the late night dinner should be avoided. There is one very good study published in JCM, our very impressive journal, and they showed that the same quantity of meal, same calories, and same content, macronutrient composition, 6 p.m. and 10 p.m. Same individuals. So once they ate the food at 10 p.m., the glucose levels were 10 milligram higher. The free fatty acids levels were higher. So you got a lot of these metabolic parameters, they do change. Even with the same quantum of the meal you eat at 6 p.m. and 10 p.m. So the reason was because you you express more insulin response to the meal. And all anabolic hormones, they are maximum at night. Your insulin is high, GH is high, cortisol is low, catecholamines are low, you gain more weight. And then after eating late, you sleep. So once you sleep, again it all goes adipogenesis. And they have also shown that incretin response, it has also got a circadian variation. So it is biological clock. And it is also lower if you eat at late night, as opposed to you eat at before sunset or 6 p.m. So if you eat the same food at 6 p.m., you exert a greater incretin response as opposed to you do at 10 p.m. So there are many advantages, and beside that, your GRD and all, they all go down with that. So I think eating early is also good for maintaining the weight lost weight.
And sir, what about upas and fasting?
What about the fasting?
Upas and fasting.
Yeah. Because you like intermittent fasting also, in between whenever you have urge to eat, you take a black coffee or black tea, that is a good choice. So eat the same amount, but eat less frequently. So I think that's the best answer to maintain the lost weight, and eat early. And have a good sleep. If you don't have a sleep, you have so many alterations in your dopamine, serotonin, and so many hormonal parameters. You eat in rebellion activity, you eat more. If you don't sleep, you eat more, in fact. So basically it is all eating. That's why I always say obesity or diabetes, this is a disease of tongue. Because the tongue does not get fat, but the whole body becomes fat. So it is a disease of tongue, and if you control the tongue, then I think everything will happen. When we're doing so many bariatric, I think Mohit has come? No? Okay. When we're doing so many bariatric surgeries, our surgeon, Dr. Gurpreet Singh, he is one of the very famous surgeons for endocrine surgery for the, he is with us later, and we published, I will just share with you, we published our data of a liraglutide post-bariatric surgery. So this has become now, this time it has been quoted in a ADA position statement. So this was a liraglutide in a post-bariatric surgery. You had an additional weight reduction of 3.4 kg in people, those who received liraglutide, as opposed to those who received placebo.
Sir, cleft lip surgeries may be put some kind of protector that the child should not scrub the stitches. If we put something like that, stents, so that he can only drink with the straw, I think the majority of the problems will be solved. I have two submissions to make, sir. One is with the warnings issued by Australian government regarding the psychological and suicidal tendencies.
Regarding
the suicidal and psychological tendencies in Australia, there is a huge number of cases reported there. They have clearly mentioned the strict warnings over these. This is one clarion call. Yes, yes. And UK government has clearly banned glitazones for using without a strict use. So these two clarion call, don't you advise all our
experts? Sir, which bladder cancer?
Yes.
Bladder is a pioglitazone was incriminated, not the GLP-1.
No, I'm telling pioglitazone only.
Okay, fine.
These are lot of being used by this super rich population who is not adopting to the lifestyle changes and dietary controls.
Fine. The people, those who had like chronic cystitis and all, we usually avoid. But one should be aware because there are conflicting reports of the pioglitazone and then this.
Sir, regarding fatty liver, is there any official indication to use Wegovy or Mounjaro, or you feel that retatrutide, which is about to come, which is a triple agonist, would be a better choice or would have the official indication for fatty liver?
Sir, now we have got a data to use in people with a fatty liver disease, either MSLD or MASH, and they have shown both improvement in steatosis as well as fibrosis. So both are available. Now officially we say it's one of the indication. Suppose someone is not a diabetic and someone is even a BMI say 25. He does not fit with the known glycemic benefits. You got a known glycemic benefits. So it take away the fat from the adipocytes. So the fat related cytokine injury is gone. So it is found to be useful.
You described this as fourth pillar in checking or slowing down the progression of CKD.
DKD.
Yeah. CKD. The GLP-1 analogs.
Yeah.
But still, it has not been used in non-diabetic people for the CKD progression slowing as compared to SGLT2 inhibitors.
Yeah.
So there are a lot of trials with SGLT2 inhibitors where non-diabetic people they used and they found that CKD progression could be slowed down. Here, nothing like that. So is it official? Again, I'm asking.
Yes.
Fourth pillar.
So I'll just tell you that.
Somebody asked me.
So there are already 4 pillars. One was ARBs was the first which came, followed by the SGLT2 inhibitors.
Yes.
Followed by the phenylenone.
NSMRs.
So 3 MSMR. So mineralocorticoid receptor antagonist. And lastly, we have got now addition of a semaglutide into this. So they have data from a flow trial.
One of the Elsevier journal has actually shown it in picture.
So they have shown a data from a flow trial, and the flow trial showed the benefits even in people with this. But the flow trial also included people with obesity as well as non-diabetic people were also there.
Okay.
So I think it is going to be effective in both the scenarios, that whether you have got a diabetes or not diabetes, like the SGLT2 inhibitors.
So it may be interpolated upon non-diabetics. Right.
So the flow trial data showed, and it has also become a 5th pillar for the people with heart failure with reduced ejection fraction. छा गया? I think do that. So can you, I think the question is, can you still take the alcohol even on Wegovy? Yes, the 60 ml twice a day, 3 days after the Wegovy. Roll over. Okay. Overall, now the recent data which came from a published in the British Medical Journal. So alcohol in any way, even for a high HDL, people used to talk about, it is not useful in any way. So very right. So currently, but still our ADA still continues to recommend, because it has not been endorsed in ADA. So they say 60 ml twice a week is still recommended. It means one can continue if they are
not
on.
recommended.
Otherwise, it is not recommended. Otherwise, alcohol has no benefit.
It is not good, and
it is not good.
People develop addiction gradually. See, and
So
it is just all the bahanas people make.
No argument, very well taken. No alcohol.
GIT people will say 0 drop. WHO says 0 drop.
No.
Thank you, sir. Thank you.
Any more comments? So, right. So just give a comparator, because patient is already acclimatized. They are already sensitized to the GLP-1. So you can use the comparator doses. Comparator doses we have made ourselves arbitrarily. It is not recommended by that. Even the companies, they don't recommend for a switch. Switch is done by the patient's need and the performance of the molecule in them. So that's why we are doing a switch.
So what about non-responders?
Weight, some people may not respond. So you ask for two things. One is the more intensive physical activity, more calorie restriction, and thirdly, switch may be useful. So certainly if someone is not losing weight, means the adipocytes are too much dysfunctional. And dysfunctionality of the adipocytes is not corrected by that.
So can price be the criteria to switch, as people are saying Monjaro to Ozempic?
Ozempic to?
Monjaro to Ozempic, price be the criteria to switch?
Right, I didn't follow.
Cost?
Cost I think will drastically come down. You see that if you switch from tirzepatide to semaglutide, if they already lost 5% or even more than that desirable weight, say someone has lost already 10 pounds. And now I think the cost is going to come down much. So we are very targeting very aggressively. So I think this is a good number at our clinic, that 70% or 72% of the people are having a hemoglobin A1C below 7.
Thank you so much, sir, for such an interactive session. Now I request our chairperson to felicitate our respected speaker, Dr. Anil Bhansali, sir. Dr. Shefali Bansal ma'am, Dr. X. Kumar sir, Dr. Pradeep Kolekar sir, please come on the stage to felicitate our chairpersons. Dr. Prabhakar Tiwari sir, Dr. B.M. Loya sir, Dr. Vijay Saxena sir, and Dr. Dinesh Upadhyay sir. Sir, please join us in lighting the lamp. Thank you so much, sir. For the next session, I invite Dr. Rahul Chodha, sir, and Dr. Rahul Gupta, sir, as our chairperson. Dr. Rahul Chodha. Currently serving as assistant professor in endocrinology.
Now may I request Dr. Mohit Bhandari sir come and join us on the platform and speak on the simplified algorithms for physician to treat obesity.
For 2 lectures, so I'll summarize at the end with algorithm, but I'll start with interventions in obesity and type 2 diabetes because I think algorithm will come to play when you know what are the interventions. Without knowing what are the actual interventions for type 2 diabetes and here in Bhopal. I'm a bariatric surgeon, College and PG Institute. Welcome all of you to come and visit our campus anytime you are free. The other 2 centers I represent is IRCAD India, which is one of the most advanced robotic and minimal access surgery, specifically Eli Lilly and Novo Nordisk, and also Boston Scientific, we as surgeons, it is very important to declare what sort of practice you have, and because this is an obesity lecture, all of them in huge numbers. And not only that, I have performed them in huge numbers, I have published a lot of data on each, and we work together to bring all the innovations in the field of bariatric endoscopy, because from surgery now to the drugs, endoscopies in between is also filling a lot of gaps. This is the new addition to our team. Dr. Phoebe used to be at my place. We published a lot of articles with David. I am a surgeon. We have an endoscopist, and now we have a physician. So I complete the circle in my team, and so that's the thing. So the message is very clear at the beginning of this lab. It's even better than human theaters to learn and practice procedures. Now coming back to the topic, we all know that Ozempic and Mounjaro are secretly shaping the waistline in India. This is a very important graph, and you see that even though we are talking about 15 to 20% total weight loss, not 25% total weight loss, at bariatric surgery we are still at 35 to 40% total weight. We will have a role or not, I'm going to talk about when I conclude in my last lecture, but we still see that gap exists. You are talking about the GLP-1s, the GIP and everything. We as bariatric surgeons know about GLP-1 and GIP since last 45 years. You know how? We know because when we do gastric bypass operation, this hormone is secreted in huge numbers. And thinking about them, in fact, there is something called as a foregut hindgut hypothesis. And what does that And what does that mean? That if you eat food and somehow after eating food, that's what is known as the ileal break, and that's what we use in gastric bypass, bypass operation. When we do a gastric bypass, the food relay the gastric emptying. It can cause several other mechanisms we have known. But things did not change, and we always thought that obesity medicine is not going to grow. It will remain into that 3 to 8% of total weight loss bracket. And so bariatric surgery was done in huge numbers until the newly approved drugs, which were really approved for obesity apart from type 2 diabetes, changed everything. This is 15% weight loss. I think Dr. Bhansali discussed in greater details about how these drugs are changing the outcome, so I'm not going to go into the details of it. But you have tirzepatide, which is even better, and in a head-to-head comparison, there is no comparison. Tirzepatide is way better than semaglutide. And you would see that in terms of type 2 diabetes also. I mean, I would say that when the patent goes off, that drug patients without type 2 diabetes, the results are phenomenal in terms of weight loss. But when we do it in patients with type 2 diabetes, somehow we don't have good weight loss. I don't know the reason why. Maybe we can go into the details and discuss, but this drug here, it has changed everything. Even in patients who had severe diabetes, it has caused good weight loss apart from great diabetes resolution. So I'm seeing it's a complete change. I'm not going to go, but this is another drug. To me, retatrutide will improve and further strengthen the field of obesity medicine. We would never know what mechanism we can debate, and there will be a lot of contradicting data which would be presented, but this is going to happen. This is a very important paper we published long back, and we decided that patients are of 4 types. There are hungry brains, there are hungry guts, there are emotional eaters, and there are slow burners. Now you see the slow burners are 12%. Unfortunately in India there are 80% slow burners. So you will have patients who would eat less yet gain a lot of weight. And we decided the algorithm on the basis of this. But before bringing you to what obesity interventions I perform as an endoscopist and as a surgeon, I want to draw your attention to this slide that obesity is a very chronic, relapsing, multifactorial disease, even more chronic than malignancy, because patients with malignancy, they die no matter what. Patients with obesity, they live a very long life. And at the same time, we realize that we need an obesity board, just like a tumor board, to treat obesity. And this concept is going to come very, very soon. You will see that international institutes of importance and national institutes of importance will create an obesity board. You will have a bariatric physician, you will have an endocrinologist, you will have a metabolic bariatric endoscopist, a surgeon, you will have a plastic surgeon, because when these patients lose massive weight, they have a lot of skin hanging problems, drooping of breast, a lot of problems related to thigh, arms and buttock, and then lifestyle maintenance center. So this is going to be the obesity board. We can choose what and when to refer, when to treat ourselves. But let's first discuss about different modalities to treat obesity. This is months to 12 months, and these have been doing a great job. Let me be honest with you. Please do not compare them with semaglutide or tirzepatide, and there is no argument to say this is a meta-analysis of 20,000 procedures. We could see very good weight loss and were there, but my life actually changed. We don't want the saliva of the patient to come on the physician, and all the intragastric balloons being done by endoscopy were very prone to spread the COVID virus. So we decided let's get something there, and then what we came with a swallowable balloon where you do not require any surgery, endoscopy or anesthesia. What you essentially do is ask a patient to swallow a capsule. The capsule, once he swallows, goes inside the stomach. There is a tubing or a catheter attached to that capsule. You fill that capsule, which has a balloon inside, with 550 ml of fluid, and then you remove the catheter and patient can go home. So this is a very simple video of how this happens. So you can see that the patient comes inside the hospital, and we explain the patient that a swallowable capsule will have to be put, and you just have to take it with water and gulp of water or a cold drink or whatever you like, and then this particular capsule is being shown to the patient, that this is the capsule, and it's just like any other normal capsule. So you can see there that it's a white capsule and it has a catheter attached to it. So the patient will just drink it with water. I will position the capsule on the back of his tongue. I'm sorry, so I'll position it at the back of his tongue and he'll drink water. And once the capsule has passed, I'll take an X-ray. Now with the recent catheter technique, we need not do an X-ray also. It's the Stillet technique, but with the old versions, we need to do an X-ray and just check what is the position of the capsule. Bring the We have been doing this since last 4 years now. We have done it to the families. So you can see this is a family of 4 people. They're all brothers, sisters, and wives. And we are doing it, all of them together, do not want a drug, do not want a surgery. They just want something which is non-permanent, because one of the things about thousands and thousands of patients in my clinics, they come on a very regular basis to do it. In fact, today at Bhopal at Her Health, we are doing 4 patients. So they come, they swallow a capsule in front of me, there is a balloon, it remains for 4 to 6 months. After 4 to 6 months, the balloon ruptures automatically into the stomach and it passes off in the motion. And patient lose good 15 to 20 kilos of weight. There is no, usually not a side effect of these balloons, because very, very soft. Older burn 4% of total weight loss, which means a 100 kilo patient would lose on an average. The maximum weight loss can go up to 30 kilos, but on an average, you will lose around 14%, which is 14 kilos of weight loss, which is 32.7%. Comorbidity resolution, type 2 diabetes, 58%. It's not bad. Good days, the injectable GLP-1s were not available, so we combined the Allurion swallow balloon or swallow pill with swallowable balloons, and the result are actually equal to bariatric surgery. Let's talk about us endoscope inside the stomach and suture the stomach wall to make it shorten. So this will convert the entire stomach into a tubular structure. So you can see that we put a scope inside, and it's a double lumen. Very interesting procedure, and we have been doing it on quite a regular basis. I was the first Indian surgeon to perform endoscopic sleeve gastroplasty, and I have trained more than 500 gastroenterologists all across the country to do this particular procedure. We brought this to India when this particular device was not even approved in India, did all the clinical trials for them, got them approval through a CEDESCO, and now this procedure is being practiced all across the country. So this is our own published data, 1,003 patients. I've done more. The smart thing I did was I chose the right kind of patient. So you see, just pay attention to the slide, the average weight of the patient was 93 kilos. So I'm not choosing a patient of 200 kilos for this particular procedure. So it will be reflective in the algorithm also. Again, 6 years data. This is the longest available data for this particular procedure. So when you are talking about drugs, we are talking about 2 years. Just 2 years, because the GLP-1s are just for 2 years. You will realize the story changes after 3rd, 4th, 5th and 6th year. With bariatric surgery, nothing, just get an endoscopic daycare procedure. You come to my hospital, I put a scope, suture inside, send you home after 2 hours. At 6 years, you have an average weight loss of 14.4%. It's a good weight loss according to me, and believe me, it is good, because we have seen with other modalities, and again, good resolution of obstructed sleep apnea, dyslipidemia, hypertension, diabetes. Yes, not a very good resolution of diabetes, because there is no hormonal change happening here. It's not a surgical procedure, it's just an endoscopic, but 53% or 51%, pardon me, is what we do is we use a Vision Pro to train surgeons. A surgeon in any other part of the world can just log in through our app, go to the Vision Pro, a little different device than the endoscopic sleeve gastroplasty. The intent is the same, suture inside the stomach and make it shorter. So this is a very good procedure. So again, this is a procedure known as a pose. In the future, this is going to be there in India. The EndoZip, it's an automated device. So even endocrinologists will be able to do what you need to do and keep on clicking. It will automatically do suturing, and within like 10 minutes or so, you can pull the device out. The stomach will be converted into a tube. So interesting days ahead for obesity interventions, and who knows, you combine with a drug and results are equal to bariatric surgery. Now let's talk about diabetes. So this is known as the endobarrier therapy for type 2 diabetes. The concept is not old. It was first described by Milone, where he said that if we do not allow the food to pass through the entire duodenum and the first 50 to 60 centimeters of the small intestine, that is a jejunum, and the food does not come in contact with the bile at that stage, type 2 diabetes is treated. It's a very interesting concept, and that's how the concept of endobarrier came. So what they thought, why not put a guide wire into the duodenum and put a device which can cover all the 4 parts of the duodenum and first 20 to 30 or 40 centimeters of the small intestine, and treated type 2 diabetes. So we have started this, come in contact with that, and this is again a simple scopy procedure can take patient off insulin. completely off insulin after this particular procedure in 48 hours, and patient lose 10 to 15% of weight, and the diabetes can be treated. Again, you give endoscopic hypothermal ablation to the duodenal mucosa, and you kill that mucosa which has diabetes duodenopathy, and you kill that mucosa, the new mucosa will regenerate, and that does not have type 2 diabetes. So this has become very, very easy for even surgeons or gastroenterologists. Now is the era of the magnets. No surgery is required. And that's how this magnet inside the first Indian study immediately patent duodenomagnetic ileal. The first Indian study immediately patent duodenomagnetic ileal anastomosis, the first in human study done by our group. We published anastomosis, the first in human study done by our group. We published it, and you can see that the results are already there, and now we are regularly doing it. So you see, these are things of future where all of this is going to become completely endoscopic. You deliver a magnet inside the stomach through an endoscope, bring the bowel loop up, a magnet inside the stomach through an endoscope, bring the bowel loop up. Now you can see that the bowel loop is coming close and the anastomosis is done. This is real time. It takes just 5 seconds for the anastomosis, and you can see that 2 magnets will have such a causes strain. So you can see this is a patient where you have a gastrojejunostomy done. We are giving the burns endoscopically to the outlet to narrow it down, and then we enter in this food. We want the food to stay back there. These are a very good, robust clinical trial protocol, and that's what me and Dr. Sachin we intend to do together. This is the randomized control trial. Done by Baram Abudeb and their group, where they took the good 17% weight loss only with the group which did the endoscopic sleeve, whereas 23.2% at 2 years, where they combined the 2 therapies. Now, somebody of you in the hall can argue that how do you attribute this weight loss to? Whether it is because of the drug or because of the endoscopy, you confuse between the two. But the problem here is not that. The good thing is that in both these patients, the dose of tirpazetide was just 0.5, semaglutide was just 0.5 milligram. So what I'm trying to explain here is that if somehow these patients, Ali said he used liraglutide, made several protocols. This is a group of people where all these people have made up protocols. There is so much of publicity around obesity. Initially, only bariatric surgeons were treating obesity. Now suddenly all of you have entered into the field. The patients have become much more aware about this disease called as obesity, and now they are coming out for treatment. More and more patients are seeking surgery. They are seeking endoscopic treatment, coming out for drugs. So it's a complete win-win situation. But these are the surgical procedures. Just wanted to show you because you should know that there is something called as a laparoscopic sleeve gastrectomy. So we just cut this tire like a gun 1, 2, 3, 4 times. And now seamlessly you can go up and do the gastrectomy. At the same time, there is something called as a gastric bypass. In a bypass, you bypass a part of the intestine, create a roux loop, and then anastomosis. This 30 ml pouch, and a small intestine is being anastomosed with it, not close to the patient. So this is the console, and I can fire the staplers. Surgery is getting much more easier. Even non-skilled people can do most of this. Make another small hole into the intestine, and this is the surgical thing happening. So you see, this is the if we have a patient between 27 to 35, what they can afford, and we have our own protocol. If you want, slowly we start you on anti-obesity medication. Any have gone to obesity physicians and is asking these days is what will happen to surgeons like me? What will happen to surgeons like me? Will we go out of job because of Mounjaro, Ozempic, Retatrutide? This is going to happen, and you know how many numbers of these are there? 80%. So this is responders. The poorer patient, what happens to that guy जो ठेला चला रहा है, उसका BMI 50 है, and हमारी कंट्री में पॉसिबल है क्योंकि यहाँ पर 5 रुपए में समोसा. We have patients, cardiac patients who are on aspirin, they stop taking the drug. So those are the anti-obesity medication, but they're going to come ultimately to surgery. So I think healing starts from home. I'm sorry, I apologize, I was late because I went on a bike ride 60 kilometers away to Narmadapuram and went to a beautiful ashram to take blessings of one of our very including drugs for obesity. But the operation or any intervention, including the drug, is determined by the profile of the patient and guided by the finding of analysis of our prospectively maintained database. As physicians, our files and everything is being prospectively maintained, and we do a third-party audit to publish that data every 6 months. There is something called as a dendrite registry from UK. It preserves our data as a third party and it audits it. So please do that as physicians, because you would...
Data. During residency, we studied about this surgical, what sorts of complication you are facing.
So I think endoscopy has less complications as surgery, but still if you are suturing inside the stomach, it is a big possibility that you might take colon while you suture, because these are full thickness bites. You might take stomach, you might take gallbladder. So there will be a 1 to 2% complication rate, not very high. Leaks are not common with endoscopy. With balloons we have seen ulcers, patients having severe GERD and not able to tolerate a balloon. Yeah, these things can happen and they are common. And not able to tolerate a balloon, yeah, these things can happen and they are common.
Balloon, I think, sir, you can remove, but by suturing, as you mentioned, it will go to long term into. I think, sir, you can remove, but by suturing, as you mentioned, it will go to long term into fibrosis part. Any chances for over time, sir, rupture, or any chances for over time, sir, rupture or something? They may need reversal or something other
So it's a very good question. So yes, it's a permanent fibrosis, and for it to reverse is very, very difficult. Go in with a scissor and cut the suture, but it's actually not.
Thank you, sir.
It's a very good question. If there are chances of malignancies, yes, we can miss them on endoscopy. You require a very good endoscopic ultrasound and somebody who has experience to go with this fibrotic area inside and judge the malignancy. So you are correct, there's a problem there. We have never had such a case, but when we suspect something, at the end of this presentation. So this is very simple. I'm not going to go into a lot of details. I already discussed about it. So, we open endoscopy. So this is very, very important question. And term hai, bar-bar kahan drug lagate rahoge, it would be a problem. Uske itte side effect of pulmonary artery hypertension, not able to walk. Suppose patient is responding. बताइए आप में से कोई भी blood pressure का medication छोड़ता है क्या? कोई नहीं छोड़ता. कोई भी diabetes का medication भी नहीं छोड़ेगा, रोज ले लेगा. किसी को blood thinner चल रहा होगा. Diseases. If you are not ready to take a chronic treatment for a chronic disease, this is going to be the biggest disaster. It is going to be a failure. In fact, if you do not follow protocols with these drugs, you will end up losing muscle mass because you are not doing resistance training. And if you don't do 2 days of in a week of resistance training, you lose that muscle mass, and when you leave the drug, you gain all the fat mass back. So the problem here is that, first remember, these drugs are forever drugs, and let me be prepared. If I have obesity, whether it is genetic, whether it is environmental, I should take the treatment first. And iska sabse pehle, is algorithm ka to tab tak koi matlab. Where I go for a bike, do 2 days a week of resistance training, I should not leave the drug. I should take the drug, and I should at least be prepared to take the drug lifelong. तो पहले तो हमको physicians को attitude change करना पड़ेगा, क्योंकि अगर हम patient को अभी I was speaking in a gastroenterology conference. A very senior gastroenterologist at Amritsar started arguing with me and said, obesity तो disease है, lifestyle modification से ठीक होना चाहिए. You should ask everybody to exercise. Exercise does not cause weight loss. There is no weight loss with 100 से 1000 कैलोरी आप बर्न, वो घड़ी वाली कैलोरी सब गलत रहती है जब तक कि आपने चेस्ट स्ट्रैप नहीं पहना हो, प्रॉपर VO2 max कैलकुलेशन ही हो. सबकी घड़ियां दिखाती है, किसी की तो 2000 भी दिखा देगी, 1000-1200 तो सबकी दिखा देगी. अब 1000-1200 कैलोरी मान भी लिया जाए वो सही है, बट एक्चुअली इट इज गलत. इट्स अराउंड 700 किलो कैलोरीज जितनी आप बर्न करते हो हाफ मैराथन में. आप घर आइए, एक समोसा और चाय, उसमें आपकी आधी कैलोरी तो वहीं कंज्यूम हो गई. वो बचा हुआ आप लंच तक आओगे, आप पूरा खा जाओगे. So if you are going by that principle कि यार मैंने तो सुबह हाफ मैराथन दौड़ी है, अब मैं दोपहर में आके बढ़िया बियर पीऊंगा, चिकन खाऊंगा, रात में भी पार्टी करूंगा, आइसक्रीम भी खाऊंगा, so you will end up having 5,000-6,000 calories in a single day. And what is the message here? The message is lifestyle modification is necessary, but it is not the treatment. आप सिर्फ लाइफस्टाइल मॉडिफिकेशन करके ओबेसिटी को ट्रीट नहीं कर सकते. इट्स नॉट अ डिजीज ऑफ डिसिप्लिन, इट्स नॉट अ डिजीज ऑफ कि बिल्कुल प्लस माइनस. इट्स अ डिजीज विच इज जेनेटिक, विच इज एनवायरमेंटल, इट इज मल्टीफैक्टोरियल. देयर आर पीपल हु ईट वेरी लेस yet they gain weight because they are able to lose weight. So let's come to the algorithm. We have to use anti-obesity medication after lifestyle modification or with lifestyle modification. और ये कौन से patients होते हैं जो less than 5% weight loss करते हैं 3 to 6 months में. इनको आप immediately लेके आइए and start them on a GLP खेलने की आदत होती है, gambling. The addiction with the gambling goes away with Ozempic and Mounjaro. The shopaholics जो खूब शॉपिंग करते हैं, मेरे जैसे लोग रोज कुछ ना कुछ नए जूते खरीदेंगे, नए कपड़े खरीदेंगे. इफ यू स्टार्ट ऑन ओजेम्पिक एंड मुंजारो, शॉपिंग टेंडेंसीज कम. सो आप जो बात बोल रहे हैं बिल्कुल सही है. लेफ्ट एवरीथिंग, यू नॉट इंटरेस्टेड ओनली बिकॉज होता क्या है कि अल्कोहल लेने के बाद वी वांट टू ईट ऑल्सो एंड वी आर नॉट एबल टू ईट. वो खाने के लिए अरुचि सी हो जाती है. सो यू आर नॉट द वन. देयर इज अ वेरी स्ट्रॉन्ग डेटा, वेरी वेरी स्ट्रॉन्ग. अ मैकडोनल्ड बर्गर and a Pizza Hut pizza has become smaller and smaller in the US because every other patient is on these drugs. Lifestyle modification. अब अगर आपका BMI 30 to 35 पे है, प्लस आपको टाइप 2 डायबिटीज भी है, एंड अगेन आपने एंटी ओबेसिटी मेडिकेशन ट्राई कर लिए हैं. नाउ देयर इज अ प्रॉब्लम वेयर यू फील कि यार ये मेडिकेशन से या तो मुझे साइड इफेक्ट हो रहा है, या मैं इसको कंटिन्यू नहीं कर पा रहा हूँ, या मुझे इसको लो डोज पे लेके आना है. कंबाइन इट विद एन एंडोस्कोपिक थेरेपी. Our data shows you come to our clinic, we will put a scope, suture and shorten your stomach. आप बोलोगे सर पहले मुझे 14 मिलीग्राम मुंजारो लग रहा था, अब मैं 5 पे ही खुश हूँ. I am able to manage my weight with 5 milligram मुंजारो. I would say that if you are able to be on 5 milligram मुंजारो or tirpazitide for all your life with one endoscopic daycare procedure, I think it is worth it. If it is there, if at all it is possible, and long-term data shows that the drug of the dose will not increase. So you can go again 30 to 35 with type 2 diabetes, metabolic syndrome, you can consider an option. And this is where bariatric endoscopy will fit in. It is less invasive, it is reversible, it is repetitive. With class 2 and class 3 obesity, अब तक तो हम इन पेशेंट्स में सर्जरी ही कर रहे थे. As per the OSI guidelines, they stop the drug and then they gain some weight. So to me, above a BMI of 35 with comorbidities and above a BMI of 40 are surgical candidates. और ये सब surgeries हैं: sleeve gastrectomy, gastric bypass, one anastomosis gastric bypass. Again, I'm not going to show you and bore you with these videos of these different kind of surgeries. But what I would say is that if the patient regain weight after bariatric surgery, so we have to first identify the cause. कि behavioral है, anatomical है, hormonal है, and then we go with a stepwise approach. Dr. Bhansali already published the data on liraglutide. Now we are publishing post-bariatric weight regain data on semaglutide and tirpazitide also. And a lot of data. In fact, to be honest with you, we've gone down. And now the GLP-1s can be used as a primary therapy, bridge to surgery, after endoscopy and weight regain start करिए. Patient respond नहीं करता, उसको ESG add कर दीजिए. 40 above आपको दिखाएगी कि प्री ऑपरेटिवली किन पेशेंट्स में आप ओजेम्पिक यूज कर सकते हैं, और पोस्ट ऑपरेटिव हैं पेशेंट्स को जब तक इंश्योरेंस कवरेज भी मिल जाता है, उसका इंश्योरेंस का काम, एंड देन वी ब्रिंग देम ऑन द ओटी टेबल. सिमिलरली कॉम्बिनेशन थेरेपी. बट आई वुड जस्ट कम डायरेक्टली टू द टेक होम मैसेज. व्हाट इज टेक होम मैसेज? ओबेसिटी ट्रीटमेंट नीड्स अ स्ट्रक्चर्ड एल्गोरिथम. अब आप मेरा एल्गोरिथम कॉपी मत करो, आप अपना बनाओ, पर उसको बनाने के लिए यू शुड हैव सम डेटा ऑल्सो. कि आप मुझे बताओ मोहित, मैंने ये एल्गोरिथम बनाया, मैंने 20,000 ओबीस पेशेंट्स क्या वेट लॉस है, इसका भी डेटा आपको मिल जाएगा. फार्माकोथेरेपी एंड एंडोस्कोपी को यू कैन कंबाइन, एंड अ मल्टीडिसिप्लिनरी टीम अप्रोच वेयर अगेन आई सेड obesity board is the most important thing. Make a obesity board and treat obesity like an institute. Don't treat like an OPD. That's the only message I would give. So again, thank you very much for inviting me, and if there are any questions, mortality. मोर्टेलिटी सर 1 year मोर्टेलिटी तो बहुत कम है, तब तो पैरामीटर्स इंप्रूव होते जाते हैं बहुत ज़्यादा. मोर्टेलिटी अर्ली हो सकती है बिकॉज ऑफ पल्मरी एम्बोलिज्म, सडनली पेशेंट को क्लॉट जमा हो गया. मोर्टेलिटी 1 month पे हो सकती है बिकॉज ऑफ अ लीक which you could not manage. 1 year के after mortality is very rare. There will have to be some cause of that mortality. Case reports suggest one important thing जिसमें हो सकती है, that is an entity known as superior mesenteric vein thrombosis. We do not know why it happens. Maybe because of dehydration, maybe because of some of the issue, but otherwise I have not seen 1 year mortality. 1 साल के बाद देखा नहीं.
There may be more outliers.
Outliers, and plus I think जो 1 year mortality can be because of myocardial infarction. Sometimes the patients have coronary artery.
Richly deserves the standing ovation.
Fields.
Yes, sir.
And can you share one of the most difficult case you have faced?
Yeah, very good question. So one of the most difficult case I have faced is a 410 kilo patient. And I have a video of that patient, how we shifted. So we brought the patient inside the operating room and we tried to put him on the OT table, but we could not. So So we did that surgery on the bed, on the hospital bed, and we did a sleeve gastrectomy first. After optimizing the patient for 3 months in the hospital, attempted at least 10 to 12 patients who are above 200 kilos. We had 3 mortalities out of those 10 patients. So I will agree that yes, I have my own share of problems. But the issue is not mortality. The issue is why these patients take access to a bariatric surgeon so late in the history of obesity. They have been 200 kilos since 10 years. But why do they come so late to us? That's something which we are never able to understand. Maybe that's why I'm saying counseling and,
Consider as a disease.
Yes.
They say it's an eating disorder, it's a lifestyle problem. That's why I think Amritsar meeting, I think what you are telling, is still many people argue in OPD also that it's a lifestyle problem, why I should take medications. And some people consider even as a social stigma, that even for obesity you are taking medication. But in fact, people has to understand it's a chronic relapsing.
Feel GERD and GERD-like symptoms or nausea and vomiting. But actually that should happen. Because if that is not happening, you will not lose weight also. But most of these patients, we bring them back to the hospital, hydrate them well, give them antiemetic, some steroid, and they do very well. The balloon removal rate for me usually has gone down to 0.01% now. We do it quite a regular basis.
Fibrosis you do or
0.01% now. We do it quite a regular basis.
Fibrosis you do or sleeve gastrectomy.
That can I already explained.
Nutritional absorption.
Yes, they will have to be on supplements for 6 months, and some who have deficiencies for lifelong. And just wanted to tell you something, that when we have Ozempic and Mounjaro giving such beautiful amount of weight loss, please take good 1.5 gram of protein per kg body weight, very essential, resistance training 2 times in a week, and multivitamins, because this weight loss is like surgery. You learn from us. We have faced all the problems. You might even have more than 100% excess weight loss, tuberculosis after Ozempic and Mounjaro because of excess weight loss, bad immunity, liver failures. These all things. It's like bariatric surgery now. So let's, we should learn from each other in terms of managing these complications. So with Ozempic, Mounjaro, I always give multivitamins and protein to our patients.
Thank you, sir. Thank you. We will take other question at the last.
Thank you, sir, for the informative session. I request our chairpersons to felicitate Dr. Mohit Bandari, sir. Dr. Shashi Srivastava ma'am, Dr. Vaijanti Kolekar ma'am, Dr. Anuradha Gupta ma'am, Dr. Salla Jain, Dr. Salla Jain,
Good afternoon to all the esteemed physicians over here. And so sorry for barging in here and interrupting your CME. And no, we are not here to talk about women's rights. But we are here to talk about women's rights. But we are here to invite all of you.
We are focusing on the midlife crisis of the women. So we scientifically plan all these sessions accordingly, and wonderful thing, prestigious workshop for us, and that was a very nicely planned by them. So I invite you all to be the part of this national conference and have a great academic feast from us. Thank you very much.
Thank you so much. Please join us.
Thank you so much, ma'am. As we move forward to our next session, I would like to invite Dr. R.P. Patel and Dr. Kailash Singhal sir to come on the stage. Dr. R.P. Patel is a skilled general and laparoscopic surgeon and alumnus of GMC Bhopal and a life member of the Association of Surgeons of India. Dr. Kailash Singhal sir is a senior cardiologist and diabetologist and MD from GMC Bhopal and a life member of CSI and RSSTI. We are thankful for them for chairing this important session. We welcome you, sir.
Everyone. The next topic on sarcopenic obesity, given by the Dr. Sachin Chitaba. So please, Dr. Sachin Chitaba. Please come.
What Mohit is. And so we have discussed a lot about weight loss. We have discussed a lot about medications. But I'm trying to again bring back you to exercise and lifestyle modification. So I'll be talking about something. Last time we discussed about sarcopenia. Today we'll talk about, are these obese people losing muscles? So what are the challenges? A new entity which is less discussed, sarcopenic obesity. Sarcopenic obesity involves an aging associated increase in adiposity, reduction in muscle mass and function. So pathophysiology of sarcopenic obesity, unhealthy diet, lack of exercise, aging will lead to mental fat deposition, ectopic fat deposition, insulin करनी है. But problem क्या है कि both of us, or most of us are now 40 plus. This is the time when we should do this intervention, bring this intervention in our life. We will not require Dr. Bhandari, will not require anyone else. That is exercise. Half an hour of exercise initial to start with. Later on, you can increase this effort to, nowadays I'm exercising around 1.5 to 2 hours. And it has been 8 long years that took me to this kind of intensity of exercise. So dear friends, this is very important and this has to be taken care of because it will lead to the pro-inflammatory cytokines, increase in leptin and decrease in adiponectin. The adipose tissue, there will be more lipotoxicity, accumulation of immune cells and chronic inflammation. And see what will happen to the muscle just because of this. There will be increase in mitochondrial dysfunction, oxidative myostatosis and anabolic resistance. What is not D? This will hamper with respect to body composition abhi tak karwaya hai. Since these days I'm going to a gym. Also we can have that kind of machine jahan pe aap aisa kheenchte hue aap aisa dekhoge. So that is not very reliable. But dear friends, you need to sensitize yourself. This is the time when we should actually be seeing as a physician. हमें लगता है ये सब तो फालतू है, ये patient attract करने की चीजें हैं. No, but it is important. It is important the moment you see और आप exercise करते हो muscle component बढ़ता है, तो आप काफी excite हो जाते हो and the moment and ये एक प्रेरणा का काम करता है. And that kind of prerna is required in life. So the clinical consequences of sarcopenic obesity is like it increases all-cause mortality, morbidity with respect to CVD related to hypertension, lung disease, metabolic complications like dyslipidemia, insulin resistance, cancers, other clinical conditions like hospitalization, and geriatric syndrome, decrease in physical activity level, functional limitation, disability, fatigue. Lot many things, they go up because of sarcopenic obesity. तो आप तो बोलोगे कि यार मैं तो बहुत मोटा हूँ, बढ़िया है, मेरा तो मुझे बीमारी कुछ हो, ऐसा मिसकंसेप्शन भी होता है, फिजिशियंस भी कहते हैं कि यार अगर आपका वेट अच्छा है तो एटलीस्ट यू हैव अ रिजर्व कैपेसिटी टू फाइट बैक. But there is a component of sarcopenic obesity, if it is there, so that statement might not be right. There is the chances of cancer and CVD. अगर ताकत कम हो जाए तो dear friend you. So this is again data with respect to males and females, normative data for grip strength across the life course. And UK centile shows that 10, 25th and 50th, again the cutoff points have been shown. So they have quantified into 27 kg for males. The time duration. देखिए मैडम ने बहुत promptly किया. This is good. But so this is how you can test yourself. If you are, इस बीच में अगर आपको समय लग रहा है तो it is sarcopenia. Somehow, somewhere, more than 30 seconds. It should not be more than 30 seconds. So how many of you needed your hands? That is something, is a matter of question. How fast did you get up? These are the things which needs to be analyzed on our behalf. So suspicion of sarcopenia or what is known as reduced muscle strength is present if the maximum head grip strength as measured with a dynamometer is less than 16 kg in females and 20 possible without running. This is something which we are doing, and the gait speed measure via its poor physical capacity and grip, lower limb, the SARC-F grip strength or chair stand test. Third is secondary sarcopenia, assess comorbidities. What are the other conditions which can lead to this? Severity like muscle strength, function and mass, gait speed, and these are all the 400-meter walk test, and shared decision making, the tailored management. So this is how they recommend it should be managed. And these are some of the strength. They say how much difficulty do you have. They say how much difficulty do you have in lifting and carrying 10 pounds, approximately it amounts to 4.5 kgs. Assistance in walking, how much difficulty do you assistance in walking, how much difficulty do you have walking across a room? Rise or aware of these kind of things, you will apply this on your patients also. And how many times you have fallen? And how many times you have fallen in the past? Sarcopenia. Required to see, these are the things which they are assessing. And the hand grip dynamometer, there is a very typical dynamometer which is very famous, but you can use the usual ones also. There are some research dynamometers which are very specific. Early years of life. And when I came to Bhopal for MBBS, I was just 48 kgs. I'm 5'10". One of the doctors said, this is way back, some 1993. Doctors said, this is way back, some 1993. He just asked me to make सब चीजें younger age में बहुत जल्दी acquire होती है, and later on it can continue as a good habit for long over the years. It will prevent obesity, but that awareness was not there. So the muscle strength cutoffs, hand grip, we have already discussed about this, and so the lower limb muscle strength, again there is a particular thing which can measure it, and diagnostic procedures for the assessment of sarcopenic obesity. This is a beautiful Nature's paper which is talking about screening high body mass index of waist circumference based on the ethnic cutoffs for obesity. High risk based on the ethnic cutoffs for obesity. High risk of sarcopenia to your patient. Step 2 is altered body composition. You can see increased fat use muscle mass. If there is no complication, it is stage 1 sarcopenic obesity. If there is presence of at least one complication attributable to sarcopenic obesity like metabolic disease, functional disability or cardiovascular or respiratory disease, it is stage 2 disease. This is how they classify and they diagnose this sarcopenic obesity. And there are obesity. And there are papers which talks about and so what is the treatment? Definitely hormonal replacement therapy as and when required, testosterone, SARMs and other therapies. There are therapies which are in process. For the moment you take this drug, sir was describing, I think it was Delhi, sir was describing this process. The moment you lose weight, actually you are losing fat between the muscle fibers. And these fibers which are left after losing the fat, they are weak. They take time. They need some strength to regain. That is the problem. That leads to sarcopenia. And this is myostasis. You need to decrease inflammation and increase physical function. So exercise and nutrition interventions to prevent this sarcopenic obesity, and what these trials have concluded. Let's see. Life and sprint trials studied older adults 70 to 90 years as risk of frailty and disability. Participants were assigned either healthy aging education or multi-component program like physical activity and nutritional counseling. Duration was 2.6 years. Both trials showed fewer disability events in the intervention group. In sprint, women had less decline in hand grip strength and small loss of lean mass. So findings indicate that non-caloric restricted multimodal interventions can preserve muscle mass and function and reduce frailty risk even without weight loss. Even if you are not losing weight, क्या फायदा यार मेरा वजन तो कम हो ही नहीं रहा. Please subject yourself for exercise. Even if you are not losing weight, you are gaining muscle mass. It is something which is very important for elderly. It is something which is very important for all of us primarily, because we are not sensitized for it. So the exercise, nutrition and neuromuscular electrical stimulation, these are three interventions for sarcopenic obesity. This is a systematic review. Exercise led to decrease in body fat, decrease in fat mass, decrease in waist circumference, LDL, increase in hand grip, increase in gait speed, and mixed aerobic plus resistance training and led to increase in resistance also. Neuromuscular electrical stimulation, decrease in body fat, decrease in waist circumference, increase in skeletal muscle index. And nutrition, increase in fat-free mass, increase in head grip. So you are actually having all the parameters are going towards the favorable side with respect to exercise, with respect to NMES, and with respect to nutrition. A combination of the three can work well. Treating sarcopenic obesity in era of incretin therapies. You just cannot stop without talking about incretin today. The perspective and challenges, incretin therapies show promise in weight reduction and physical improvement in younger population, but are minimally studied in older adults. This is something the paper talks of. This is a diabetes paper. The medication can be used to treat severe obesity related complications which older adults with sarcopenic obesity are prone to developing. These medications need to be used cautiously among older adults, considering potential muscle mass loss and adverse events. If you are prescribing any of the two molecules, please check their exercise profile, how they are exercising, and motivate them to go slow. Treatment should be coupled with exercise and dietary modification. Monitoring patients every 1 to 3 months during ramp-up phase. Monitor for elderly. Effect should be defined according to the health goal. The future of treatment of sarcopenic obesity in the era of highly effective. Ongoing trials are highly effective. Ongoing trials are testing activin type 2. Key takeaways are testing activin type 2. Key takeaways are sarcopenic obesity equal to coexistence of obesity and reduced muscle decrease in muscle strength, physical function, and decrease in muscle mass. Exercise is the cornerstone. Combined resistance plus aerobic training. Nutrition, adequate protein enhances exercise benefits. Again, I am re-emphasizing, please take care of your protein intake. We as a doctors are very poor protein takers. क्योंकि हमारे मन में बैठा हुआ है कि वे प्रोटीन लेने से गुर्दे खराब हो जाएंगे. Even as doctors. There are three types of as doctors. There are 3 types of whey protein. मुझे लगा opportunity है तो क्यों ना बात करें. तो tolerant है, तो वो आ सकता है आइसोलाइट में. तो आइसोलाइट में लगता है आइसोलाइट में. तो आइसोलाइट में ये आइसोलेट वाला पोर्शन हटा देते हैं. तो इसमें ये आइसोलेट वाला पोर्शन हटा देते हैं. तो इसमें एक स्कूप विल गिव यू 30 ग्राम्स ऑफ प्रोटीन. और आप बोलोगे यार साहब मैं ये लेता हूँ और मेरा पेट खराब हो जाता है. बहुत ये लेता हूँ और मेरा पेट खराब हो जाता है. बहुत लोगों को होता है, गैसेस होने लगती है, इंडाइजेशन होने लोगों को होता है, गैसेस होने लगती है, इंडाइजेशन होने लगता है. उनको वे प्रोटीन हाइड्रोक्सिलेटेड जो वे प्रोटीन हाइड्रोलाइज वे प्रोटीन इज रिड्यूस फैट while preserving muscle function. Reduce fat while preserving muscle function. Thank you. Thanks a lot. Cheers.
Thank you, Dr. Sachin, for a nice lecture. Would you like to say something about the resistance band, which is now getting popularity nowadays?
So क्या हुआ कि रेजिस्टेंस बैंड की बड़ी कहानी है कि
nowadays?
So क्या हुआ कि रेजिस्टेंस बैंड की बड़ी कहानी है कि फार्मा वाले गिफ्ट्स लेकर आते हैं. कई बार क्या होता है कि वो गिफ्ट्स तो जब मैंने पिलाटेस ज्वाइन किया, दिस इज अगेन अ फॉर्म ऑफ एक्सरसाइज जहाँ स्ट्रेचिंग होती है, वहां पे मैंने ये रेजिस्टेंस बैंड का उपयोग चालू किया तो मुझे अपने पे बहुत हंसी आई कि क्या कर रहा था मैं. हमारी मैडम की जो साइकिल्स बनती है ना, वो रेजिस्टेंस बैंड वहां बन रहे थे. तो कार के पीछे हैंगर में लटक रहे थे. तो दिस काइंड ऑफ अवेयरनेस I had regarding those resistant bands, but they are very helpful. Resistant bands की आप एक्सरसाइज करिए, मैं खुद करना चालू किया मैंने. It is very simple. Simple आपने एक होल्ड किया, ये ऐसे ही आप करते हो, then you can go for this. All kind of exercises are done by those resistant bands. पैर पे रखा, फिर यहाँ गाड़ी में जो साइकिल्स लगते हैं उनकी, वहाँ वो बंद रहा, वो resistant band काम आ रहा है. So this is how the things are. Yes. यूरिक एसिड मोस्ट ऑफ मार्कर है, तो वहां थोड़ा सा कॉशियस, अगर 15-20 से ऊपर है तो सोचिएगा.
It's a marker of metabolic syndrome. So it's an insulin-mediated metabolic syndrome. So it's an insulin-mediated increase in urate absorption from the PCT. So if someone is having a fat loss because of these molecules, GLP-1 and all, even you take a 1 gram or a 1.2 gram of a protein, the delta rise in the uric acid may not be substantial. So that's one. Secondly, you treat only when there is either declining renal function or there is a recurrent gout, or otherwise you don't treat if the person is asymptomatic. You don't require it.
Yes. So very true. This is how which is not justified. We hardly see, well, पैर में थोड़ा सा दर्द हो रहा है, ना गाउट जैसी रिकरेंट स्वेलिंग है, ना कुछ है, कुछ भी नहीं, बस यूरिक एसिड साथ आ रहा है. And the patient is on febuxostat and he is happy कि मैंने एक दवा ले ली. हमेशा दिमाग से बात करता है. And anything which is affecting your gut is affecting your brain also.
It is improving, in fact.
Yeah.
It is improving, in fact, because these are all called as a brain-gut peptide, PGP.
Yes.
It was used when we used to read in our physiology, and then when I joined DM, even that was so many hormones. It was a cholecystokinin, GLP-1, GIP, bombesin, and I think so many, I don't remember even. So many hormones are basically involved in the gut. They send the appropriate signals to the brain, and then your appetite is regulated. So gastric fullness and all. So I think after this surgery, if you see the GLP-1 levels after the bariatric surgery, say almost 40 to 50-fold higher. What we are getting with the same GLP-1, we are increasing the serum GLP-1 levels at least 8 to 10-fold higher. It's around 40-fold higher after the bariatric surgery. So that suppresses your appetite, and that regulates your, increases the satiety.
So all the microbiota plays any role?
Yes.
So recently now they are talking about the gut microbiota is also playing a role, because if your gut activity is okay, if your GLP-1 is intact, GIP is intact, so gut microbiota also plays a role in that. So now people are even talking about it for the treatment of obesity, improving the gut microbiota, so that can also lead to some heat. I told you that your brain says don't eat, your heart says you eat, your stomach says don't eat, but still you eat. So I think that's a problem.
थैंक यू. तो हमको जो आयुर्वेद वाले कहते थे कि हर बीमारी की जड़ पेट है, तो शायद वह सही है.
वो सही है, बिल्कुल सही है. आयुर्वेदा I'm not against.
शायद ही नहीं, वो सच में सही है. वो सच में सही है. Anything you will find there's a पेट है ही नहीं. So I think you do try this. So this is all problem starts with eating.
पर्यूषण पर्व के बाद भी सबको आपको ऐसा ही अनुभव होता होगा?
Yes, I do one fast in a year only. So on that day I feel there is nothing.
सर ये एकादशी पे उपवास रखना या उसमें ये जो हमारा ट्रेडिशन है ना वो इसीलिए था.
मेरे ख्याल से क्या है, उपवास करने के साथ में तो वो तो बहुत अच्छा कंसेप्ट है उपवास करना.
नहीं, पर वो जो आप साबूदाने की खिचड़ी खाते हो और साबूदाने के वड़े खाते हो,
उपवास करते हैं, फलाहार लेते हैं,
दैट इज बैड.
अगर हम उपवास का
मतलब तो कुछ नहीं करेंगे, पर
I think if you say उपवास, then I think you don't, you just not nirjal, but उपवास means pura उपवास. What we have observed after our Ramzan, most of the people they gain weight during the Ramzan. Possibly in a fear of hypoglycemia, they eat more. Because the next day they have not to eat, even they have not to drink the water. So in a fear of hypoglycemia, they eat. Then means it's a partial fasted that way. You gain, you land up in more weight. So even you do a Ekadashi Vrat, but if you eat in the night more sabudana, you eat more.
Yes.
Because you are hungry for the whole day, so you eat more.
This is more of an emotionality.
Yeah.
Hedonic eating or emotional.
That too, जो फलाहार बनता है उसमें बहुत घी और तेल होता है. We are having a rich fat.
Sorry. No, microbiota cannot be taken. They are usually talking of.
You're talking about Sporelec or
they are probiotics.
BSL3.
No. They are probiotics. Microbiota, the people are using a fecal transplant.
Yes.
So they are having a different type of samples of the fecal, but I don't remember those bacteria. So they are there, and then they transplant it.
Thank you, sir.
Thank you, sir. Thank you. I will request you all for please come for the group photograph. And thank you. Thanks a lot for patient hearing. This was a very successful masterclass. And sir. Sir. मुझे सर से क्या फेलिसिटेशन ये क्या कर रही है, ये सर प्लान नहीं था. थैंक यू. ऑल द बेस्ट.
Thank you so much, sir. We sincerely thank all this academic initiative. Wishing you continued learning and professional growth. Thank you.